We are live in 3, 2, 1. We are live now.
Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Embryology Excellence Series Part 2 in collaboration with Oxy Awareness. It is a webinar on troubleshooting in assisted reproduction technology, ART. Now, I would like to hand over the session to Dr. Manisha Jain.
Thank you so much, Dr. Vishal. To begin with, I'd like to introduce the conveners of this program, Dr. Randir Singh sir and Dr. Monica Singh ma'am. Dr. Randir Singh sir is already well known. He's the brainchild, who's the brainchild of this webinar. He's the organizing chairperson of the National SR 2023, and he's already a straight certified embryologist, director of Bhopal Fertility Testing Baby Center. He was the immediate past chairperson of MP SR. I'd like to request Dr. Randir Singh sir to kindly say a few words about this webinar.
Yeah, thanks everybody, all dignitaries that this platform I have introduced for the SR embryology, and because we need a knowledge updated of the new ART Act. So earlier, 1 week earlier, we had done a presentation on the new ART Act, and this is going to be a continuation part with this. And I am very thankful to the Foxy, and I think we can, without wasting time, we have got many things. So continue, please.
Thank you so much, sir. Next co-convener is Dr. Monica Singh, ma'am. Madam is already well known to everyone. She has many achievements to her award. She has been the honorary secretary of the MP chapter research. She has been the vice president of Bhopal Observatory Society.
Thank you, Dr. Manisha. I think we will not waste time. We will not waste time.
Okay, ma'am.
Thank you so much.
For the proceed, hand over the further process to Dr. Monica Singh.
Yeah, it is with extreme pleasure that we start the episode 2 of Embryology Excellence series, in which we have a mix of the team of perfection and symbiosis. We have a new look in this webinar because we are involving lab practices. We are involving a lot of AIT, and we have fresh new topics in which I would like to thank our President, Dr. Jaideep Tank, Secretary General, Dr. Madhuri Patel, Madam, Vice President, West, Dr. Ajay Mane, Chairperson, Public Awareness Committee, Dr. Priyankur. Now, I would like to invite Dr. Priyankur Roy to say a few words about this webinar and welcome our dignitaries. Over to you, Priyankur.
No, we have to introduce the Priyankur, Mona.
That's okay, sir. Not a problem, sir. That's
yes,
fine. Sure. Thank you so much. Thank you so much, Randir sir and Monica ma'am, for.
One more thing I would like to say about Priyankur is that Dr. Priyankur, 1 minute. Not only he is the chairperson of Public Awareness Committee of Fox, but he's a very great human being, a very adjustable and a very compliant person who takes everybody along, whether it's seniors or juniors. And at present, he is at the prestigious post of President of WETOG, which is a matter of honor for the whole country. We are so proud of you. Over to you now.
Thank you so much, ma'am. It really gives me immense honor to be part of this Embryology Excellence series, and thank you for having the Public Awareness Committee in this program. So I would first of all like to thank Jaideep Tank sir, Madhuri Patel ma'am, Dr. Ajay Mane sir for giving us guidance through this program, and of course the coordinators, Dr. Randir Singh sir, Dr. Monica Singh ma'am, for arranging the whole webinar, for inviting and involving all the faculties for this webinar. Thank you so much. I would also like to thank Dr. Manisha Jain and Dr. Purnima for conducting this webinar. My heartfelt thanks to our chief guests, Dr. Dheeraj Gada sir, Dr. Narendra Maludra sir, Dr. Rishikesh Pai sir, and Dr. Amit Bhatki sir, all of whom who have joined us, and the guest of honors, Dr. Virendra Shah sir and Dr. M. Srinivas sir as well. So I would like to thank our speakers, Dr. Nagori sir, Dr. Pratap Kumar sir, and I'm sure the talks are going to be very enlightening. The chairpersons, Dr. Ashish Kale and Dr. Manoj Chelani sir, are going to add to the comments for the talks as well. And the moderators, of course, who better than Dr. Naina Patel ma'am and Dr. Randir Singh sir, and our expert panelists, Dr. Ashwini Kale, Dr. Charudat Joshi sir, Dr. Feshi Lewis sir, Dr. Mahesh Koregal sir, Dr. Manish Pandya sir, Dr. Rohan, a very close friend of mine, Dr. Varsha Jain, and Dr. Yatendra Verma sir. So I thank all of you for joining this webinar. Thank you for enlightening all our viewers, and I'm sure with the Public Awareness Committee, we are going to have an excellent webinar. And this being the first webinar under Dr. Jaideep Tank sir's leadership, so I'm looking forward to this webinar as well. So I hand over this platform back to Dr. Monica ma'am to take us through the scientific session, and I'm sure it's going to benefit all the viewers who will listen to this great speakers and the panel.
Yeah, thank you everything. Thank you for everything, Priyankur. And I will just do a little correction here. Dr. Jaideep Tang sir and Dr. Madhuri Patel were there for the previous webinar. That was the Embryology Excellence one. And today they will be gracing our function again within a span of less than a week. So we are really honored and privileged. And the greatest person on Foxy right now is the president. We are proud to have Dr. Jaideep Tang amongst us. He will be gracing the function soon, and he has so many feathers in his cap. But the latest is he's taken over the largest organization of gynecologists, which I heard in the latest MCM in Hyderabad. It's 43,000 members now. So sir would be leading the Federation of Obstetrics and Gynecological Societies of India, and he is also the deputy secretary AOFOG and immediate past chair of FIGO, Committee for Safe Abortion. Welcome, Dr. Tank, to our webinar. Now I would like to introduce our Secretary General, Dr. Madhuri Patel, ma'am, who is a very keen academician, a very dynamic Secretary General of FOXY, who is leading the organization from front, working 24/7, and at the same time, she's always connected to every member. There's not a single phone call she doesn't reply or doesn't answer. So most welcome, madam. Next, I would like to invite our Vice President, West Zone, Dr. Ajay Mane sir, who is a member NIMC, National Inspection and Monitoring Committee of the PCPNDT wing in the Government of India through FOXY. He is a practicing medical legal consultant since last 18 years, and he does it totally honorary. He has been the chairperson, official OMOG's website, chairperson, Sexual Medicine Committee, chairperson,
Monica ji.
Yes, sir. Yes, sir. So I welcome you, sir. We are honored to have you amongst us. Next, I would like to welcome again our chairperson, Public Awareness Committee, Dr. Priyankur Roy, because of whom this webinar has seen the light of the day. And now to introduce our chief guests and guests of honor, I hand back the session to Dr. Randhir. Dr. Randhir, are you there?
Yes. Yeah. I'm there. Sorry. Yeah. So it's my privilege that I'm having my all.
Sir, before Randhir sir, before we go on, we have Ajay Mane sir with us.
Yeah.
So can we? Ajay Mane sir will, as the VP of the committee, we will want to take his blessings for this webinar, sir. So we request Dr. Ajay Mane sir to kindly say a few words, sir. He is of course the VP of the committee, and it's a pleasure. I consider him to be my elder brother. So it's a pleasure that sir has joined us, and I request sir to kindly say a few words of blessings to all of us present over here.
Yes, sir.
Yeah, thank you, Priyankur and Monica ji. So in fact, it's my good luck that Priyankur is working under my head, basically. So I am privileged to have a young and dynamic boy and a young brother like Priyankur. So thank you very much for calling me, respected chief guest of honors, and all the respected speakers. Basically, embryology is a main pillar of ART. Because if the embryologists do not do proper work, all are in vain. So embryology is to be given that importance because it is the main pillar. Circus ka beach wala that is the embryology. So best of luck, Randhir bhai. And so everybody is having efforts, but you are the main pillars. So I like the topics today, optimizing IUI results. So very good topic. Then ovulation induction in ART. It's the basic things. Obviously, the speakers are very well known, and ART law, because the law is amended just now. So we need to know all the proper things given in the law, and we should follow that. So thank you very much, and best luck Priyankur, best luck Monica ji, best luck Randhir sir, and best luck for this webinar series. All the speakers and the panelists and moderators. Thank you very much for calling. Thank you very much.
Thank you for honoring by your presence, Ajay sir.
Yeah, I'll just take one few seconds. Ajay Mane sir, you have given a beautiful concluding remark that is the circus ka pillar hota hai, sir. That reminded me, मेरा नाम Joker of Raj Kapoor and all. Really, embryologist, and if they do a good job, ethical, and we under them give a best results. Now, Gala sir is here. I'll introduce him later on because now the IVF, he worked, I think, 50 years back. It was only 5% results. Now we are going 50 plus. So you have highlighted in one single sentence that embryology is a single pillar of that. Thank you, sir. Thank you. So I think now, Dr. Priyankur, can I continue?
Yeah, of course, sir.
Yeah,
I was just thanking Ajay Mane sir for being there and for his comment.
So
Please go on, sir.
so today's chief guest, as you know very well, my mentor, my senior, who has taught me from ABC, Dr. Dheeraj Gada sir. Dr. Dheeraj Gada sir, we have got the four chief guests, Dr. Dheeraj Gada sir, then Dr. Narendra Malhotra sir, Rishikesh Pai sir, and Amit Patki sir. So I'll introduce first Dr. Dheeraj Gada sir. He has given whole life to the infertility. He was the first person to introduce the IVF and ART. I'm not going to read because I know him from एवरीथिंग. मैं सर की बिल्कुल एक एक व्हाट आई कैन से नब्स को पहचानने की पूरी कोशिश किया है 50 साल से. सो आई नो आई एम नॉट गोइंग टू रीड फ्रॉम दिस. आई नो व्हाट फ्रॉम माय हार्ट. धीरज गड़ा सर was the first person in the central India to start the ART, and in 1984 there was a great tragedy of Bhopal gas tragedy, and he started the first sonography machine in MP, and at that time Mr. Arjun Singh was the CM, so he's the pillar of that, and he has got what not. And if anybody gets the Lifetime Achievement Award by Indian Society of Reproduction and Indian Fertility Society, it is the highest award. And he has been the past president of the ISAR. So I think I'm very welcome and very honored. Our Sir का आशीर्वाद हमेशा हमारे साथ रहता है. Thank you, sir. Sir Gada sir, if you want, we want that few words to be please told by you, sir.
Thank you very much, Randir, for your kind words. There are a lot of my colleagues from ISAR on this panel, and they are highly supported. And as Dr. Mane said, that yes, the very first day, the moment I had trained Virendra in embryology, I used to tell that he's my backbone. So in my IVF team, if I was successful, then it is because of my embryologist. And Virendra has done fantastic job. So, as Dr. Mane said, embryology is the real pillar of the success of IVF. And this there are a lot of missteps happening. And now with increasing the awareness among the population, you cannot afford to have any misstep occurring in the IVF laboratory. And we have to be very careful. The information and technology is taking over a lot of our problems. And we should be more careful and do more sincere work to get the better results. I don't want to waste a lot of time because there are nice lectures, and I wish this seminar all the best. Thank you very much.
Thanks a lot, sir, Gala sir, and we are very privileged to that. And our next the chief guest today is none other than the Dr. Professor Narendra Malhotra sir. He's a managing director, and he has been the first person to start everything. If I remember, it was the Ghulam Nabi Azad 15 years back when we were not used to do the sonography of our own. He was a person who, with the Union Health Minister, fought for us. He was a FOXY president at that time, and we has done a lot of things. So he, as at present, director FOXY Smriti, then Director Project Positive Health, then Director International Relations, SAFOG, National Director Ian Mold, and then past President SAFOG and WAPOM. And he was a past President Foxy and past President ISAR. So I think whenever he joins, Dr. Monica, he's there. So if he can say.
Sir is right now not there. So
okay, so be in touch whenever he comes. We'll again. So now, Rishikesh Pai sir, we know he is being the pillar and he's a elder brother to me. He's available at any time. रात को 2 बजे भी phone करो, he's available. Monica Randhir bolo what you want. And in my successful ISAR conference last year, he was a backbone along with Nandita Palshetkar ma'am and Smita ma'am. And he always guided me. Randhir, audio visual ऐसे होना चाहिए. When I told him, sir, my audio visual will be that कि ये मेरी बेटी की शादी है. I'm talking about that. So this points is the greatness of them. And we have seen the last 1 year how the FOXY has risen as soon as he joined from a yatra from Rishikesh to Kolkata. So he has united all the people and main aim to the society that Gadha sir, Mane sir, still we are getting the anemia patient. So his main fight was that anemia has to be ruled out, because any parameter that, like Modi sir says, Prime Minister, that we will be, economy will be the best. But I think the lowest maternal mortality rate and infant mortality rate is the ideal status of the whole world. So he has been many things. He has got many publications, 5,000 plus. He has got the many memberships and all. Founder chairperson of special interest of American Society. And recently, in his feather was that he has been in FIGO, a board member of the FIGO. So welcome, sir, Rishikesh sir. And I think Monica, Dr. Monica, is there. So he will join later on.
So sir did not pick up the phone, and Malhotra sir is in OT.
OT.
Malhotra
Dr.
sir is-
Priyanku, Dr. Priyanku, you have informed them, no? You have a call. Yeah. Okay. Then we have got the next. Amit Patki sir, he's going to be, he's again like brother, because I don't know whether he's elder to me or not, but he's again very, very helpful to us. He has a great practitioner at the Mumbai and honorary professor, Sumaya Medical College, consultant, Khar, Hinduja and Surya Hospitals, representative in SR, government council in ICOG, president-elect for coming SR. He's going to take a charge in just, I think, 15 days after in the Bhubaneswar Element Conference, and West Zone RCOG, and he has done more than 35 publications, 50 book chapters, an international patient. And I was privileged, proud that I myself and Monica, we have done a many research paper for male infertility in coming last 5 years. So Amit Patki sir, if you are there, sir, please say a few words.
A very good evening, and thank you very much, Randir and Monica, for inviting me to this Embryology Excellence Series Part 2. And I'm very happy and glad that Foxy Awareness Committee led by Priyankur and Vice Chairperson Dr. Mane are also present. I'm very happy that we have finally acknowledged that embryology and embryologist is a vital part of a successful team. And I'm happy you all are holding such meetings where you will also bring about awareness on the new ART law and the bill. So I'm quite excited to listen to the galaxy of speakers that are there today. And I wish both of you, Randir and Monica, the very best. I take this opportunity to ask every ISAR member to please vote in ISAR, because I think y'all should be the ones who should decide who should be leading you. And in this, I please request all of y'all to vote for Randir and Monica. Both of them have worked very hard for ISAR. We all have been witness to the Bhopal conference, and I'm sure they will enrich the committee by their presence. I wish you all both the very best now and in the future. And I look forward to seeing most of you at Bhubaneswar. Thank you very much and have a great evening.
Thank you, sir. Thank you so much.
Amit Patki sir, there are two more contestants, Dr. Priyankur Roy and
yes,
yeah,
Priyankur is also there, so I wish him. And who's the fourth one?
Manoj Chelani. Manoj Chelani.
Manoj is also there. Hi, Manoj. Yeah, so please, all those who are listening, please get onto the link and vote for all these 4 people and all the candidates that you wish more. But I think we need to increase the voting. We need to have a fair representatives of the electorate. So best of luck to all 4 of you.
Sir,
Yeah, I second Amit sir, and best luck to Randir bhai, Monica ma'am, Manoj bhai, and my young brother Priyankur. So we all should promote the voting, as Amit sir said, and best luck to all of you. So you
I
must
totally
win.
agree with sir. In last Foxy presidential elections, Sunita ma'am, we have increased to 20%. So I think the percentage of voting should be there. And I was just talking to my close friend. I just was discussing why there is a voting less percentage. So he told, ISAR ने हमारे लिए क्या किया है? What I am saying, see, this is the thing. So I think I told you, first vote, choose the people, and what coming sir, इसी बात पे इसार ने क्या किया है sir? My president is going to be now Amit sir. We started soon after Bhopal conference. Monica started Perfection series with the permission of Nandita ma'am and Sunita ma'am. Sir, this embryology excellence, I want that from Bhubaneswar, this excellence should be a part of a regular ISAR webinars, and I'm the in charge of accreditation, ISAR accreditation of the IVF labs. So we have to accredit our all members so that
Correct.
it's continuous, sir. So I will be requesting soon, but as soon as you take the charge, sir.
Correct.
Thank you. Thank you, sir. Thank you, sir.
रणधीर भाई, can I interrupt?
Yes, yes, sir. Yes, sir.
या जिन्होंने आपको पूछा ना इसार ने क्या किया, उनको बता ना कि एआरटी लॉ जो आया है ना, ये सिर्फ फॉक्सिया और इसार की वजह से ही आया है.
Yes, sir.
है ना?
वही
So
सर.
your life is easy with these people. So
Yeah, sir. That's we have done, no? So that's we have to say, and we have really we are united, and India is going to be the one of the best. I was listening by Mane sir, Banker sir produced a very good talk in ACE Bangalore. India is going to be the largest centers of ART in the world. So if the ART law is ethically passed, सर अगर हम लोग सब एथिकली काम करते तो आज एआरटी लॉ जैसे कहीं पर सर देयर इज अ कंट्री इन नीदरलैंड जहां पे देयर इज नो कंज्यूमर फोरम, you know, sir, because there is no unethical practice. So we will do, sir, and under the viewership and under the leadership of Amit Patki sir, I'm sure, sir, we all will do. We have got a very good young people and we are seniors like you, sir, Mane sir and all, and think we'll take you very well. Thank you, sir, Amit sir. So now Dr. Monica,
Yeah.
yeah, you can introduce the guest of honors.
Yeah, with extreme pleasure, I introduce our guest of honor for today. Can I have the CV, please? Dr. Viren Shah is the first embryologist of Central India with an experience of over 3 decades. Sir has taken training at several international centers. He has been working so hard in the last 30 years. I'm a witness to it because he was the first embryologist who visited our center and gave us the first IVF and ICSI pregnancy, first twins, so many other things. And he is very well respected, very well known all over India, abroad, and he is the key partner and the key fulcrum around which GADA IVF and healthcare system developed and set the precedent for IVF centers in MP way back in I think 1980.
84, 80s, 84, 80s. Yeah.
84. Honored to have you, Viren sir. We would like to have a few words from you, sir.
Hello, good evening, everybody.
Good evening, sir.
I welcome you in Embryology Excellence Series 2, sponsored by the Foxy Awareness Committee. I thanks Dr. Mane, Dr. Gada, and Dr. Patki to give the importance to the embryologists. Very few center. Thank you very much.
Yes. Yeah, Dr. Monica, next. So I'll introduce, yeah, I think Monica is calling. So I'll introduce our present chairman of ISAR Embryology, MS Srinivas. He's a core, I think he's the person, though it's a recorded, but I'll tell you today what the BJP is there, it's because of unity of the RSS 100 years back. So it's grassroots. So MS Srinivas is the person who made the all embryologists of the India under the banner of ACE, and he made his identity. And because of that identity, ISAR is bound to have them included in that. And as Mane had told, we are the fulcrum. The circus ka hota hai. So all ART center, as in previous lecture, Banker sir told, India is going to be largest ART treatment in the whole world. So I think you're the person behind that. And you are the chairperson embryology, scientific director, Narayan Health University. And one more feather to Srinivas is that he's running a good courses for the to train the embryologist, which is NCI recognized and all, so that is very helpful in the future. And he has performed more than 30,000 IVF cycles, I think the largest in the South India. And I think because of you, the South India, the whole people from the Gulf and everybody is coming. So you are the main center. I think 50% of the whole cycles of India is under you. So, and you have marked all the research centers. You edited the book also. So platform is for you, sir, Srinivas sir, and you're the key person. Please say a few words and bless us for this webinar.
Thank you very much, Dr. Am I audible?
Yes, sir.
Yes, thank you very much, Dr. Ranveer Singh, for inviting me for the second webinar. Yes, this is the time actually everybody has to vote because Ranveer has just mentioned the percentage of vote is less. I think we have left with another 4 days. it is mandatory, because we always blame the rule now actually, because when you actively participate to this kind of association, try to bring in the variation what you find in the embryology or a clinical side, then the main body will be able to recommend. So, like you said, what is done by the ISAR? ISAR is a private the organization. Any the government association board, they might take a no advice from us. The final decision will be from them actually, because there also experts will be there, whether it's a clinicians or embryology side. Without wasting the time, I would like to thank Randir Singh and entire committee, for inviting me for this webinar. I will be, maybe in between I will be disconnecting. Definitely, I will join in between. Thank you so much.
Thank you,
Thank you,
sir, Srinivas sir. As you mentioned very well, sir. Any health minister or prime minister, the act in the parliament, they invite Foxy, they invite ISAR, they invite IFS, so ACE, so all jointly. So any association with a good representation that matters and who fights for that. Thank you, sir, Srinivas.
Just one more word actually. See,
Yes.
this act has
Yes.
come in last year, almost 1.5 year old now. Each and every state supposed to make a state board. I started no, really hard working when BJP government was there in Karnataka state. Unfortunate to that, after Congress I came, just 10 days, 5 days became before I have been elected, selected as the expert committee member. So this is how the government works.
Yeah. So thank you, sir. That's there. You have to fight. Like Srinivas sir, in
Yeah.
MP, I was lucky enough, sir, Mane sir and Amit Patki sir. I was lucky because my health minister was from my alumni. My health secretary is a medical doctor. So always be that. So that's very good, sir, Srinivas sir. If you have ART committee member, I think the South will do all the ethical practice and do that. Thank you, sir. So Dr. Monica, you can continue now.
Yes, after the introductions are over, we come to the core scientific program. And to start the same, I invite my coordinator one, Dr. Manisha Jain, who is a very accomplished gynecologist of my city. I'm proud to have her in my team. She's treasurer of Bhopal Obsgyne Society, a very active executive member of MPOX. She has been a core organizing team of the ISAR Bhopal, which you witnessed and which was very successful, and she has a long way to go. I welcome you, Dr. Manisha, and please conduct the program. I also introduce my second coordinator, Dr. Purnima Tiwari, again a very dynamic young gynecologist belonging to our city, who is working at the prestigious Apollo Sage Hospital, alumnus of prestigious institutions of India, a very high-ranking academician, winner of Manish Banker Prize, which is going to be awarded to her in Isar Bhubaneswar. Congratulations, Purnima, and I'm proud to have her in my team. So, Manisha, can you please start the program?
Thank you so much, ma'am. With all the words of wisdom from our senior dignitaries and blessings of the God, we proceed with the academic session. To begin with the first session we have with the as a topic of optimizing the IY results, and the speaker is Dr. C.B. Nagori, sir. And to chair this session, we have Dr. Monica Singh, ma'am, and Dr. Priyanka Rai as chairpersons. Dr. Monica Singh, ma'am, is already well known to us. She's been the organizing secretary, vice president of BOGS, and in the co-convener of this program. And next chairperson is Dr. Priyanka Rai, sir. Priyanka Rai, sir, is already known to us. He is the associate professor at Lord Buddha Kushi Medical College, chairperson of the Public Awareness Committee, and it's because of him that this webinar is seeing the light of the day. He's also the president of the FIGO VETOP. Over to chairpersons to please for the further proceedings. Thank you.
Dr. Priyankar, would you like to introduce Dr. Nagori?
Yes. Yeah, I'll
Yeah,
do that, ma'am. Sure.
Please.
Thank you. Thank you so much, ma'am. Thank you for the introduction, Dr. Manisha. And it's such a pleasure to introduce none other than Dr. C.B. Nagori, sir. He was, I would just tell, I'm sure he has got a long CV, but just to say one thing, that he's a teacher of teachers, have come to even to Siliguri to train us over here. And it's such a pleasure to see him around. And whenever he sees someone who's even so junior to him, like someone like me, he always acknowledges. So that's a great quality, I would say, of a great person. So thank you so much, sir, for agreeing to give this talk. And I invite you to this platform. I do not want to stay in between you and the listeners who are, I'm sure, here to listen to your talk, sir. So it's a pleasure to have you. Thank you so much, and the platform is yours, sir.
Thank you very much. I'm audible now, Priyankur?
Yes, sir.
Yes,
Yes,
sir.
sir, you're
Okay,
Yes,
audible.
sir. You're
Sure.
audible, sir.
You can start sharing your
Yes,
slides, sir.
Thank you very much, Monica, Randhir, Priyankur, and all the organizers for inviting me on this topic. I'll be discussing under four certain heads, that is counseling, diagnostic workup, indication, stimulation protocol, monitoring, how many IUIs, IUI technique, and the luteal phase support.
Sir, can I please request you to make it full screen, sir?
Oh, just a minute. Okay.
Yes, sir. Perfect. Thank you so much, sir.
The counseling is extremely important in IUI because many a times in a busy schedule, we may not talk much with the patient. But two things are very important in counseling. Number one is the sexual relation can be kept on any day, irrespective of the day of IUI. Otherwise, I have seen that many people, they don't keep the sexual relation for 10 to 12 days, something like 12 years old whiskey. They feel that that semen is very good, and that's why they don't keep the relation. And then they give the sample which is hopeless. So that's why purposefully, even I remember the 3 days before I got a patient who had undergone many IUIs but had never kept the relation from the day of menstruation till the day of IUI. So positively, you have to tell the patient that you can keep sexual relation any day, irrespective of the day of IUI. And second, the most important thing to be discussed with the patient is that it is not IUI that gives you the pregnancy. Most of the time, patients believe that once the IUI is done, they conceive. There are so many other things which are equally important, like a plate, that IUI is simply a one dish in the whole plate. And you cannot satisfy your tummy by eating only one thing. And that should be emphasized to the patient that each and every aspect in IUI is extremely important to get a positive pregnancy test. And that's why your indication should be proper, stimulation should be proper, monitoring, triggering, semen processing, insemination, and luteal phase support. If you miss a single step, you fell down. It's not that IUI that gives you the pregnancy, but each and every step is important. And if you miss a single step, then you just fell down, you don't get the pregnancy. This should be emphasized to the patient, and that will help you to get a good pregnancy rate. Now, singleton live birth rate with one cycle of IVF is not significantly different than 3 cycles of, if controlled ovarian hyperstimulation plus IUI with FSH. So, the 3 cycles of IUI will be much, much cheaper than the one cycle of IVF. And that's why the IUI should be tried properly to all the patient. If somebody, any one of you have attended the conference at Salzburg, the title of the conference was the revival of IUI, because in Western countries, everybody used to do IVF to all the patients, and they realized that lots of patients do conceive with IUI before subjecting them for IVF. And that was one of the excellent conference. And these are some of the papers which have now come in the literature after that conference. And this is one paper that the 3 cycles of IUI gives very good results equivalent to one cycle of IVF. Evidence-based systemic review suggests that IVF is not more effective than gonadotropin with IUI. So that's why the indications are very important. So what do we mean by IUI failure? I will consider IUI failure means when the selection is correct, stimulation is done by gonadotropin, monitoring is done by at least the color Doppler, and optimum luteal phase support is given. And even then, if the patient does not conceive in 6 cycles, I'll consider it as an IUI failure. Otherwise, if any of these things are not obeyed properly, I will consider it as a personal failure rather than IUI failure. So don't blame IUI. IUI is a no man's land. The gynecologists have not the good setup of IUI, and IVF consultants may not be interested in doing IUI. And that's why IUI is a no man's land. So at least whenever you analyze the patient, how many IUIs have been done on the patient, then try to see whether the stimulation was done by gonadotropin, whether the color Doppler was used to assess the patient, and the luteal support was given properly, then and then you should consider it as an IUI failure. Otherwise, you can try IUI on these patients and you can get very good results. Now, the diagnostic workup, in a diagnostic workup, the most important part is the tube-ovarian relation in case of IUI. Now, I would like to tell the physiology that there is ovary of imbricata which is attached to the ovary, and at the time of ovulation, it contracts and brings the fibrillar end closer to the ovary so that it completely covers the ovary. When it covers the ovary, the columnar epithelium, the ciliary movement starts, and that ciliary movement causes -1 millimeter mercury pressure, and this -1 millimeter mercury pressure will suck the ova inside. That will break the septa, or that will break the wall, and the ova is sucked in. So it is the tube that takes an ova rather than the ova goes inside the tube. It's a general impression that the ova is separated from the ovary and just like a roller ball, it enters the tube. That's not correct. It's the tube that takes an ova. And that's why the correct TO relations, tube-ovarian relations are extremely important before taking the patient for IUI. But I don't mean that for each and every patient you should undergo the laparoscopy before doing an IUI. You do a good ultrasound. If uterus is freely mobile, if the ovary is freely mobile, then tubes are not seen in sonography. It means the patient is normal, and you can do IUI to this patient. Otherwise, in a long-term infertility patient, when the mobility is restricted either of the ovary or of the uterus, then you may suspect something and you may go for endoscopy to this group of the patient. So that's why if you want to assess the tube or the tube ovarian relation, then the laparoscopy is always the gold standard evaluation that is done. Routine ovarian reserve testing is not required in IUI. I have yet to see a patient who have not undergone AMH and has come to me. Surprisingly, even a regular gynecologist, when a patient goes from one to another, then the repeated AMHs are done on the patient. Even with AMH between 0.3 and 1, the ovary does grow 2 to 3 follicles after the stimulation. So if you do the baseline scan very well, then you always get 2-3 follicles on both the sides, even with the lower AMH. And we have already published a paper with 35 pregnancies when the AMH is between 0.3 and 1. Out of these 35, 32 had conceived with IUI and 3 with IVF. So what I would like to emphasize that the low AMH doesn't mean that the patient has got the poor fertility. Particularly when the age of the patient is more than 35, you have to differentiate between two groups, a patient with poor fertility and a patient with the normal fertility. So the age-related fertility decline doesn't mean a poor fertility. It may be a normal fertility also. And that's why these are the patients who definitely conceive with IUI. Now, this is very important slide that indications of IUI I have written unexplained infertility as the first, and fifth one is the unexplained infertility in IVF. So that's why don't jump for IVF. Otherwise, everybody must have observed that after 2, 3, 4 IVF failure, the patient has conceived spontaneously, and this is with almost every IVF specialist. The reason is that the selection was wrong. If you select an unexplained infertility as the first indication in IUI, and the unexplained infertility should be the last indication as far as the IVF is concerned. Now, I would like to tell you some of the commonest indication in my practice that unexplained infertility is the common indication for IUI. And I have got 170 patients for more than 3 IVF or XC failure. I never consider 1 or 2 failure because that is very common nowadays to get a patient from the fertility. Conceived with IUI of which 70% were having an idiopathic infertility. So my carry-home message is that don't jump for IVF immediately to unexplained infertility. They do conceive either with good ovulation inductions or with IUI, they can conceive very well. In unexplained infertility, superovulation with IUI has got the higher pregnancy rate than only superovulation. Now, this is to be emphasized to the patient because the patient may ask you, sir, is it necessary to go for IUI? You can explain that the IUI will increase the pregnancy rate apart from your superovulation. And when you are spending so much of superovulation, then you can spend for IUI also, and the pregnancy rate will be very good. Ovulatory dysfunction, then the IUI is the choice. I would like to tell you that up till now, in my whole practice of so many years, I've got about 6 patients of hypogonadism up till now. And I would like to inform that all the patients have conceived with IUI. So here the fault lies with the ovulation. You correct the ovulation, rest of the things are done by the nature. And this is one of the example of 5 IVF failure conceived with HMG plus estrogen plus IUI in the second cycle and delivered. So what I want like to tell you that try to find out where is the fault, and fault lies with the ovulation. So correct the ovulation, the tubes are normal, the semen analysis is normal. This patient can conceive either spontaneously by good ovulation induction or with IUI to this patient. Now, this is one of the landmark case in my practice. And because I do practice male infertility a lot, and the male infertility is perhaps one of the most neglected subject in the era of IVF and ICSI. And this is a patient who had 3 million count with 7 ICSI failure had come to me because nobody tries to improve the count in this era of IVF and ICSI. See, if I have to take a talk on male infertility, I can tell you that even before ICSI, even before IVF, you can treat medically so that you can get good number of sperm even after ICSI or even with IVF with a very low count. And that's why the medical management can improve the count to such an extent that the spontaneous pregnancies are possible. Lots of, I think 2023, April, the whole fertility study is given on the FSH stimulation for male infertility. And I think everyone should go for it, because that tells you how you can improve the count and how you can convert an IVF into an IUI cycle or IUI into a natural conception. This was the patient who had come to me for IVF, but I would have been stupid if I would have done IVF, because all the IVF were done by the quite senior and the people who established IVF in India had done. So I cannot do anything magic on this patient. But I always tell to all the students also that don't try to sail in the same boat. Always try to find out what your colleagues have not done rather than what they have done. And I could see that nobody had tried to improve the count in this patient. And I treated Professor Ishii according to Professor Ishidori's regime, that FSH thrice a week and HCG once a week. If you give it for 13 weeks, that it improves the spermatogenesis. So one of the carry-on message for the juniors is also that when you attend the conferences, then you realize that there are some points that you get which are very useful in your clinical practice. And this is one of the example that when I had heard Professor Ishidori at Bombay in Oberoi Hospital, in Oberoi Hotel, when this conference was held, and that conference was only on male infertility, and Professor Ishidori had so many talks, and he discussed that these are the bioactivity of the hormone is very low in this group of the patients who have a low count, which do not improve. Their FSH, LH are immunological levels which are normal, but their bioactivity is very poor. And if you correct this bioactivity by giving exogenous good drugs, then you can improve the spermatogenesis. I have a series of patients where I have improved the spermatogenesis by this Professor Ishidori's regime. And this patient conceived with IUI in third cycle, and as the count was 22 million, spontaneous conception occurred after 2.5 years. So this is the tip of the iceberg, that the 7XC failure patient has got 2 children today. So just try to improve the count. You can have a good success rate with IUI or with even the spontaneous conception. The motile sperm should be less than 10 million before the washed male subfertility. Mild ovarian stimulation with IUI gives very good results. There is a common question, how much should be the wash count? And there are various papers in literature which tells that 0.8 to 5 million motile sperms are inseminated, the conception rate occurs. Immunological infertility, there is no steroid, no azathioprine, nothing should be given, only IUI should be done to the patients. Superovulation with IUI should be offered as the first line of treatment in male infertility with immunological cases. Endometriosis, mild and moderate, the patient do conceive with IUI, but for third and fourth degree, there is no option except IVF to the patient. This I've already discussed, the single tube, particularly the tube that takes ANOVA. So that's why majority of cases, we never do IUI on the side on which the follicle develops and the tube is blocked. So the chances of pregnancies are very less. And that's why it should be done only on the side on which the tube is open. Then HIV positive male, HIV negative female, and you can go for IUI. There is no seroconversion either on the part of the female or on the baby. Now, the stimulation protocol is very important. I told you that first is an indication that is very important. And now I'm coming to a point of stimulation protocol. There is always a clear superiority of the low dose. This is Professor Raumbach paper. I think 2006 he had published in the Spain that clear superiority of the low dose FSH over the CC as the first line of treatment, and chances of clinical pregnancy in the first cycle is 30% as compared to 14%, and time taken is also less. And there are a lot of papers which have said that the low dose gonadotropin stimulation is cost effective and gives the better pregnancy rate than CC when it is combined with IUI. So IUI plus gonadotropin gives excellent pregnancy rate. We have devised the according to the clinical and ultrasound finding, we have got this table through which we calculate what should be the stimulating dose. And accordingly, once we stimulate, then chances of hyperstimulation is quite less, as well as the cancellation of the cycle is very less. And this is the starting dose of FSH that we calculate. We calculate, particularly the color Doppler is very important, that you do a baseline scan, do AFC, overend volume, and stromal RI, stromal PSV. That will tell you exactly how much dose is to be given to the patient. So according to the numbers, you can calculate the dose for IUI, dose for IVF, and dose for your frozen cycles also. Now, is that the stimulation is required? The absolute pregnancy rate was 8.4% with monofollicular development and 15% with the multifollicular growth. There is statistically significant in the presence of 2, 3, and 4 follicles. Level of evidence is 1A. So this is the highest evidence that if you have more than one follicle, your pregnancy rate increases, and that's why just analyze your previous cycle, and if you have got only one follicle, try to increase the dose of FSH so that you can get at least 2 to 3 follicles and you can improve your pregnancy rate. Letrozole plus FSH is an excellent combination. Either you can go letrozole day 3 to 7 or recombinant FSH or highly purified FSH can be given from day 8 onwards. Particularly letrozole plus FSH combination is very good for PCO patient. It's very good for poor responder patient. For normal responding patient, it does not increase the pregnancy rate. But here it can reduce the dose of the gonadotropin, as well as the cost to the patient is decreased and the pregnancy rates are very good. Agonists are never to be given in IUI cycle. There is no role of down regulation in IUI cycle that increases the cost and causes all the complications of it, and we never down regulate any patient. Antagonists are very useful, particularly in a thin, lean PCO patient. In a thin, lean PCO patient, the androgen level is high, and this high androgen level is responsible for the high LH surge. And premature LH surge is also equally very common in a thin, lean PCO patient when androgen levels are high. And here, I would like to not to emphasize what I did to this patient, but once again, my carry-on message is that try to analyze the prescription of your own colleague and try to find out what has not been done. And second, very important thing, because this was my first patient of antagonist who had conceived, and I read the book of Professor Roy Humberg, and still I remember the older edition of this book. Only one paragraph was written that the antagonists are promising in IUI in PCO patients. These were only the 3 lines in the whole chapter. And that's why the youngsters, I always advise that you go on reading the good books, go on attending the good conferences. You will get only few lines in, but that will change your practice dramatically. And these are the few lines which we utilize in our practice, and we can improve our practice a lot. Now, antagonist and IUI, I told you that you can give antagonist for prevention of an LHR. But the second very important use of antagonist is that suppose the one follicle is 16 to 18 millimeter and the other follicles are 12 millimeter, 13 millimeter. You wait for a day, give antagonist to the patient. And by giving antagonist to the patient, the LH surge will not occur. And by the time the 12 or 13 millimeter will reach to 15, 16, and you can get 2 to 3 follicles for IUI, and that will give a better pregnancy rate. We already discussed when the number of follicles are more than 2 to 3, then the pregnancy rates are very high. Triggering is always done by either HCG or 10,000 highly purified HCG can be given. Only one indication of agonist, leupride acetate or the decapeptyl, 2 ampules should be given. State particularly when you get multiple follicles on both the sides. Now, there is nothing like OHSS. OHSS will become a history. But when you get multiple follicles, normally gynecologists are afraid of OHSS, and that's why they are not giving gonadotropin. But if you start with the chronic low dose protocol, that is started, and then if you with these dosage, if you give, when you get multiple follicle on both the sides, in spite of that, you give glycerolic acid at 2 cc and do IUI, you will get very good pregnancy rate. So you will not get OHSS, and you can get very good pregnancy rate with this. So agonist and antagonist, you can use antagonist for prevention of LH surge, and final maturation should be done by the agonist. That will be very useful to the patient. Whenever you give agonist trigger, always remember judicious luteal support. That is the vaginal progesterone 400 milligram 3 times a day is required. And when you are afraid, suppose by chance, normally we used to give cabergoline, even we used to give agonist to the patient, but nowadays we have stopped it, because when you give agonist trigger, then the OHSS does not occur. But if you have given by chance HCG to the patient, then you can give cabergoline 0.5 milligram daily for about 7 days. Now, this is the only indication of estradiol valeriate 2 milligram 3 times a day whenever you have given agonist as a trigger. I see a lot of prescription when you have given HCG trigger or just for the sake of improvement of the endometrium. People are giving estradiol valeriate just casually to all the patients, but it is no use. It does not work at all, and that's why it should never be prescribed to the patient. The only indication is whenever you give agonist trigger to the patient, then and then GNR agonist trigger, then and then estradiol valeriate is to be prescribed to the patient. I don't go into the much detail, but when you give HCG or when you give highly purified HCG or recombinant HCG, then the minimum requirement is more than 16 millimeter follicle, 3/4 of vascularity, RI less than 0.5 and PSV more than 10. This much should be there to get an excellent result in IUI practice. Many people say that we don't have color Doppler, what we can do. I always tell them that you should be satisfied with your results, because the good instruments are your extended fingers, and you have to take the help of the good instruments, then and then you can improve your pregnancy rate very well. You may not have 3D, but at least up to color Doppler is very much necessary. If you see here also in the endometrium, the 8 millimeter endometrium with vascularity in zone 3 and 4, then you can get an excellent results in your IUI cycles. Now, if you read most of the chapters, it has been mentioned that the double IUI does not give the pregnancy rate good. It is the same as that of the single IUI. But nobody has mentioned in which patient you should go for double IUI and in which patient you should go for single IUI. Particularly when the PSV of the follicle is high, the follicle is likely to rupture earlier. And suppose there are 3-4 follicles, then the one follicle which has got the 15, more than 15 the PSV, then that follicle can rupture earlier also. So in those patients where the PSV is more, you should go for double IUI, and otherwise you should go for the single IUI after 36 hours. So when the perifollicular PSV on the day of HCG is more than 20 centimeter per second, perifollicular RI is within normal range, you should go for the earlier IUI after 12 hours and second after 36 hours. Now the million-dollar question is how many IUIs should be done. It varies from conference to conference and from person to person. But I would like to tell you what the literature says. There are very limited studies where 9 cycles are attempted. Pregnancy rate for 6 cycles is 30% and 9 cycles is 41%. And if time is not an issue, some couples should be offered 9 treatment cycles, especially when the female age is less than 35 years of age. 2 cycles of IUI at 38 to 39 years give reasonable pregnancy rate. 1 cycle if the age is more than 40. Why this is very important? Because normally these are the patients who are advised for the donor eggs. So instead of going for the donor eggs, you can try definitely good IUI cycles and the patient can conceive. So absolute minimum cycle should be 3, preferably 6 cycles. And if time is not an issue, then if the age of the patient is less than 35 years, 9 cycles should be offered to the patient. The National Institute of Healthcare and Excellence Fertility Guidelines advocate 6 IUI cycles should be given. Now, this is a very good article by Professor Royenborg in the Human Reproduction, that the UK government passed a law that there should not be any IUI. That should be only 2 years of expectant management and then followed by IVF. No IUI at all. But only the 4% of the gynecologists accepted this, and they were reluctant to opt for the expectant management or the no treatment. And there is always a superiority of IUI above no treatment proven, and that is why the parliament had to withdraw the law, and the IUI once again came in the British parliament. The law was passed that expectant treatment, and that at that time you can go for IUI to the patient, and if the patient does not conceive, then you should go for IVF. Now only few minutes, few tips for you, that no antiseptics are applied, air should not be injected, and normally the capacity of the uterus is about 0.4 ml. So whenever you take about 0.7 to 0.8 ml of the solution, just a minute. Then we do IUI with this. Now I'll tell you what happens at that time. But we normally use the same speculum from the very first year of my practice. I had a lot of Cusco speculum. I tried my level best to some of the patients, but could not negotiate the cannula. And still now they are lying in the museum specimen for so many years. I always catch it with an Alice forceps and do IUI. And because it is very difficult in Cusco speculum, I had a lot of arguments with the people, but I always used to say that I'm getting excellent pregnancy rate. Then why should I change it? And I'm always lucky afterwards that 2014 onwards, lots of paper came that the uterine contractions are useful. The pendulum has gone from one side to another side. People used to say that there should not be any uterine contractions when you are doing IUI. And now it has been proven that if the contraction occurs, the pregnancy rates are very high. And that's why we always catch it from very first day with the Alice forceps. A single bite is taken, and then try to make the cervix and uterus in the same direction, and you can negotiate the cannula very easily. Now, the very important thing is you have to do intrauterine insemination. Don't try to go to the fundus and come back and then introduce it. And whenever you do IUI, remember one thing, that the capacity of the uterus is 0.4 ml. So whatever extra is there, there are two things possible. Either something will come out and something will go inside the tube. So there is always intratubal insemination whenever you are doing IUI. And that is why the gift has gone out from the picture, that you are doing intratubal insemination along with IUI, and that is why you should take about 15 to 20 seconds to 30 seconds whenever you are doing an IUI. So intratubal insemination helps you a lot. Then allow the patient to rest for only 15 minutes, and luteal support with HCG and the progesterone should be given to the patient. So the usual complaint of the patient is, sir, सब कुछ निकल गया है, ये मेरा IUI fail हो गया. But tell the patient that the remaining amount has come out. The thing which were necessary, the semen has already gone inside, and you can conceive with this also. After the procedure, 15 minutes rest is required. This is very, I told you in the beginning, the counseling, that abstinence of less than 2 days gives a higher pregnancy rate. So normally you must allow the patient to keep the normal sexual relation before IUI, and that gives a better pregnancy rate. Our usual practice is on the day of trigger, we ask them to keep the relation. Next day, it is their choice. And after 36 hours, we do IUI to the patient. Luteal support, because you have used gonadotropin antagonist, you have used HCG as a trigger, or you have used agonist trigger. All these 4 conditions require a judicious luteal support, and that itself is a separate lecture. But the luteal support is given to all the patients. Swim up and gradient. Only one line I would like to tell you, that evidence reveals that the no sperm preparation technique is superior to any other. So at least those who are the beginners, you should master only one technique. There is no need to master all the techniques. And it varies from media to media. They will be writing some different methods. But you master only one technique and you stick to the principles of IUI, then you get a very good pregnancy rate. Oral antioxidants are very useful, particularly when there is ROS, and time should be less, between 40 to 80 minutes from preparations to IUI. It's not that you are busy with cesarean or hysterectomy and then the IUI is done after 4 to 6 hours. It's not allowed. It should be done as early as possible after your semen preparations. So just I summarize my talk, the stimulation should be done by the gonadotropin. Ultrasound monitoring by color Doppler and 3D power Doppler will be very useful. Triggering of ovulation with either highly purified HCG or recombinant HCG should be done. single IUI at 36 to 38 hours, double IUI, pre-HCG follicular PSV is more than 20. Optimum wash count should be 6 to 8 million, but the minimum 1 million is required, and luteal support by HCG or progesterone, and you can get excellent pregnancy rate. Thank you very much.
Thank you so much, sir. And I must tell all of you that Dr. Sonal Panchal, ma'am, is the encyclopedia, the god, the guru of ultrasound and Doppler. And Dr. Nagori is the god of intrauterine insemination. Those who have listened to his lecture today are blessed because, sir, there will be nobody who is so proficient in IUI before you or after you, who is so passionate about this, who is such a fantastic teacher. When Randhir and I we were younger, we used to travel abroad for Ashray. पैसे बहुत कम थे, foreign trips were expensive. So मैं questions लिख के जाती थी कि नागोरी सर के साथ लंच करूंगी तो ये पूछूंगी, you know, सोनल मैम के साथ लंच करूंगी तो ये पूछूंगी. Everybody used to be dancing and enjoying, and I used to keep pestering him. Sir, unilateral tubal block. He said, Monica, do IUI. Sir, this much million count. Do IUI. Sir, just now before the webinar, I got a pregnancy, 36-year-old woman, single tube block, first cycle IUI, she conceived. Only letrozole given, no luteal phase support, sir, because she belonged to Ayushman patient. Ayushman patient, MP government is giving 10,000 per IUI, sir, including everything. So we cannot afford any frills. She just came with a pregnancy test, and I was just doing her TVS, very beautiful gestational sac with yolk sac. So, sir, I am totally indebted to you, sir. I cannot tell you how much you have influenced my practice whole my life. And, sir, it is an honor to chair your session.
Thank you. Thank you very much.
Yes, sir. Nagori, sir, I think, sir, you know, we, as Monica told, IUI before you and after you, we cannot think that. Welcome, Manish Pandya, sir. Welcome, sir. I think you are also, I think you must be agreeing with us.
No, I would say one thing. Recently, I got company with Dr. Nagori at Hyderabad airport. And Dr. Monica, still I am student of Dr. Nagori because Nagori sir used to teach us on a slide. One slide more, next. We used to go in his clinic to learn gynecology because he was the first person who started only gynec practice. Believe me, when we are resident, no delivery, until that he is not doing any delivery. He had started IVF practice on in airport also. We had discussed everything. So he is ready to teach anywhere.
Yes,
Sir is
yes,
like
really.
that. And we are blessed with sir wisdom on IUI. And on that day also I told perifollicular flow. We heard from him. We have to see perifollicular flow. We have to see uterine artery PI. We have to see vascularity in the endometrium. Then we have to do IUI. So, sir, you are father figure of IUI. We can say Bhishma Pitama. So, thank you very much, sir.
Yeah,
Thank you
Gada
very
sir,
much,
also, if you
Balu.
remember, sir, Gada sir, yes, sir.
Yes,
You also
sir.
always teach us this. Yes, sir, please, sir.
Whenever I used to talk on IUI in our national conferences, people used to think that I am old age person and I don't have good success rate in IVF. That's why I'm talking about IUI. But I still tell you, my team will 100% agree with me that always we first try IUI if both fallopian tubes are patent. I never discourage patient to undergo IUI. And if you are coming to Bhubaneswar, you please hear me again on chronic endometritis, and I will tell you that
Yes.
number of IUI results, how they have improved with
Yes.
treatment of chronic endometritis. And I'm still encouraging that for Indian patients, where still our 70% of the population coming to us, they are from lower middle class. And IUI is a big boon for them. I thank Dr. Nagori and Dr. Sonal Panchal, madam, for excellent review of this article and excellent knowledge given to us. Thank you, Chaitanya. Thank you very much.
Thank you very much, sir. Thank you very much.
Thank you, sir. Gada sir, आपने मुझे
you.
बताया sir कि actually we are the ART people and we create the embryos outside the lab. So we are Brahma, but we can never become a natural conception. The natural conception, the queen and the king, which they have egg, has chosen the sperm. I think that is the best always. Without wasting a time, now Dr. Purnima, you can continue.
Now, Manisha is going
Yeah.
to start the second session now.
Thank you so much, sir, after such a wonderful talk and practice-changing take-home messages. We now move on to the next session, that is ovulation induction in ART. And the speaker is Dr. Pratap Kumar, sir. To chair his session, I'd like to welcome Dr. Ashish Kale, sir, and Dr. Manoj Chalani. The first chairperson, Dr. Ashish Kale, sir. I welcome you, sir. Sir is the director of Asha IVF Center and Family Welfare Committee chairperson, FOXY. He's been the clinical secretary of ISAR, executive member of IAG, and secretary Pune Ophthalmic Society in various years. And he's a recipient of various awards from IAG, AAGL, ISAR, and various other organizations.
Thank you, Dr. Jain.
I welcome you, sir. And the next chairperson we have with us, Dr. Manoj Chalani, sir. He's the director of Ayush Hospital and Test Tube Baby Center from Raipur. He's been the managing committee member, ISAR, chairperson-elect, Chhattisgarh, ISAR. He's been the chairperson of Medical Disorder and Pregnancy Committee, chairperson of Urogynec Committee, Indian Menopause Society, and he has served various organizations in different capacities. I welcome you, sir. Over to chairpersons for the next session. Thank you so much.
Thank you,
Before they
Dr.
take over,
Jain.
I'll just say one thing, Ashish. Before they take over, I'll just say one thing. Both Dr. Ashish and Dr. Manoj are very good friends, and it's been an association that has lasted for many, many years. Welcome to the webinar, and of course, thank you so much for joining. Thank you.
Thank you. It's indeed my pleasure to introduce a mentor, a friend, a philosopher, a guide, Professor Pratap Kumar, sir. He is a professor and head of the Department of the Reproductive Medicines of Kasturba Medical College, Manipal. He has hold the position of National Vice President of FOXY in 1999. He is an inspector, examiner, and advisor of National Board of Examiners. Examiner for undergraduate and postgraduates exams in various universities. He has appointed as editorial committee of the several journals. He is a president of Karnataka State Obstetric and Gynec Societies of FOXY. He is a member of Task Force of the Human Development and the Disease Biology Department of Biotechnology, New Delhi. He has several awards for his credit. So without wasting much time, I request sir to talk on ovulation induction in ART. And sir, it's really a privilege of mine to chair this session.
Thank you very much, Ashish, for the lovely introduction. Thank you, Monica and Randhir and Priyanku for inviting me. I need to be permitted to share my screens. Can the organizers do that? Okay, I'm ready. So since you had a lovely talk on IUI, I will take you through what we do for basically assisted reproductive technology, and the concept of controlled ovarian stimulation will be discussed in the next 25 minutes. And this is called as individualized controlled ovarian stimulation. I bring greetings from Manipal University from Karnataka State. We all know that when the LH surge, there will be ovulation. So the whole concept of not to get LH surge is the motto in an IVF cycle, and we prevent the LH surge. So before, how Dr. Nagori told about counseling and preparation for an IUI, we need to understand in an IVF, there are two phases in the stimulatory protocols. One is gonadotropin independent phase, and the other one is a dependent phase. And when you look at that, when you look at the antral follicular count on the second day of menstruation, from then onwards, it becomes a dependent phase. That means the gonadotropins are started at that time, obviously. But before that, there's a lot of waiting time for the antral follicles to be actually active later on. So we know that if somebody is obese, you have to reduce the weight. And if somebody is a PCOS, you treat the PCOS initially and then start the ovarian stimulation. So it's called as, independent phase. Hence, BMI has to be reduced if it's not all right before you take up for an IVF cycle. Now, important to understand is the cavity should be fine. As you look at that, the triple endometrium, triple layer should be seen well, and the cavity should not have any kind of obstacle like a polyp and so on. Only then you can take them up for an embryo transfer. So let's review the gold standards, discuss alternatives, and introduce concept of preparing the ovary for egg collection. Now, I think it's important to know about anti-Mullerian hormone. Though Dr. Nagori said about IUI, you don't have to do it, but I think it gives a very good idea in an IVF cycle. Anti-Mullerian hormone is basically, of course, AMH is a short form. A peptide growth factor is a reliable marker for ovarian aging. expression continues to increase until primordial follicles have developed into small antral follicles. And that's how it's important to know. So when you look at this anti-Mullerian hormone, they actually tell us the reserve egg quality. In other words, if you count the antral follicle, we know the number. But if you have an AMH estimated before you stimulate the for IVF, we know the quality. The normal AMH should be 1.5 nanogram to 3.5 nanogram, and that will tell us the quality of the egg. But when you look at the ovaries and like this, there are 8 to 10. I always say the number 10 is interesting. Obstetrics and gynecology, a lot of 10s, and even hormones are approximately 10. The antral follicular count must be 8 to 10 in each ovary. That's a very good response, patients. If you find less than 4 to 5 in each ovary, they become not too good responsive. And if you find more than 15 in each ovary, they are a hyper response. So remember 5, 10, and 15 antral follicle for poor, good, and a hyperstimulation. So when you look at the antral follicle on the left side, you'll realize there are only just 2 to 3 follicles, whereas this has the polycystic ovaries and the thick stroma as well. So when you always look at the iliac vessel there on the left side, you'll appreciate there are only 2 follicles there. However, that follicle may still grow and becomes a dominant follicle, which produces estrogen and causes a good endometrium. So a stimulated ovary will be either it's hyperstimulated or normally stimulated, which can be assessed at the end of 10 days of stimulation. So natural cycles were tried initially, but it's kind of given up. It's not too good for an ovarian stimulation. Clomiphene, HMG can be tried. Once again, not up to the mark, but we can try HMG or recombinant FSH and whatever you want. But literature has not proved one better than the other. Hence, you can try either recombinant FSH or HMG or pure FSH. I don't think it matters much. However, as I mentioned, in all IVF cycles, the ovulation must be there, but we should not have LH surge. That there are 2 kinds of protocols. One is agonist protocol, other one is antagonist protocol. The main story of premature LH surge means poor quality, no fertilization or very poor pregnancy rate, and cancelled egg retrieval. I get a lot of patients referral from other centers, not referral. Patients go to a couple of centers, finally they reach my center. Most of the paper says they're poor eggs, poor fertilization, and poor embryo. Why? Because they have allowed premature LH surge and not stimulated correctly. That is why we should be pretty sure as to how to prevent LH surge, and that's what my aim is today. The long protocol is not very popular at the moment, but you should know that because in certain situations, long protocol can still be done. The long means it takes a long time. Day 1 means they come on a day 21 of the cycle, and you'll find you start down regulation with GnRH analog of 1 milligram or even 0.5 milligram sometimes, depending on the level of stimulatory protocols later. And once they menstruate, you start injections. How much the dose, I will tell you a little later. However, down regulation occurs from the previous cycle of 21 days, and it goes on till the day of HCG. You are pretty sure that the LH will get suppressed. And then, of course, when the follicles are good around 18, 19, 20 millimeters, you give HCG, egg collection after 3 days, after 36 hours, and the embryo transfer after 3 days or 5 days. Now, that's a long protocol. Now, I like this antagonist protocol because they come on the 2nd day of menstruation and we start injections. After about 4 days, you call her on the 5th day of the cycle and you look at the follicle. The follicle should be 12 to 14 millimeter, and the estradiol, if at all you do, it should be at least more than 300 picogram. So antagonist is started at that time. So we start antagonist from 5th day of the stimulation. When the follicle is 12 to 14 millimeter, if it's less than that on the 4th day, you wait for 1 more day and then start the antagonist. Because if you don't start at the right time, the LH receptors come there in the ovary and they ovulate. That is why most of the people have not understood this concept of when to start antagonist. It's not exactly on the 5th day, it may be later, but remember 12 to 14 millimeters, and usually estrogen will be around 300 to 400 picogram. So the agonist, the undesirable effects are oversuppression. LH becomes so low that it affects the production of estrogen, and possibly, it becomes so suppressed, then the antral follicles are very, very low. And finally, they have a poor response. Too long, too much drug use, cost cancelled, and the cycles, and it is, of course, doesn't look so natural. So we'll realize that though it is good, it has been recommended by the Poseidon criteria that you can use agonists if you find there are poor response last time and the poor reserve. They can even use agonists for synchronizing the follicle, but my experience is most of the time it gets suppressed. And one more point is when you look at that, though the agonists are a long pre-treatment, comparatively antagonists' immediate onset of action is seen, prevents hormonal withdrawal symptoms, whereas the agonist takes a long time for it and they still have a menopausal-like symptoms. And then with antagonists, there is no recovery time for the pituitary, whereas agonists, recovery of the pituitary gonadotropin secretion after stopping treatment almost about 2 weeks. So, antagonist avoids oversuppression and poor response, effective in preventing LH surge, reduction of hyperstimulation compared to the agonist protocol, and lower cost. One more thing I used to experience was when they come on the second day, there'll be a cyst, a big cyst, sometimes a follicular cyst, because the initial part of GnRH analog, there'll be stimulatory protocol, stimulation of the ovarian tissue, and they cause a cyst. So we all think about cost, physical suffering, immediate side effects, future side effects, and ovarian hyperstimulation syndrome. Now, though we know that OHS is not so high, it can be there in an agonist cycle than antagonist cycle. But we know in an antagonist cycle, if there are too many follicles, we can give GnRH analog at the end of the stimulation rather than HCG. And Dr. Nagori clearly said, agonists, when you give, they don't have OHSS. I agree with him 100%. When I find initially I have to get worried and start about cabergoline, once I give 1 milligram of GnRH analog and freeze the embryos, I don't give anything. They don't have OHSS. So we always think, is it a waste of human resources, excess eggs, how to deal with them? Excess embryo, even worse. But at the moment, things are not so bad. We all have cryopreservation techniques, so more the embryos means more chances of stimulation. And we transfer less embryos means less chance of multiple pregnancies. So it is time to individualize more user-friendly alternatives. Now, the mindset is think preparing the ovary for egg collection, think patient-oriented treatment, and always minimize trauma to patients. Now, patient-friendly approach will be simple to follow, less side effects, more affordable, favorable treatment outcome, and less complications. So this goes on like that. But I want to just emphasize on one point here. I have done this on my own grouping in my career, in my practice, but I haven't really published this. But I think it's for clinician is important. There are 3 kinds of group. One is the best group, A group, young age, less than 35, no other problem. She has had pregnancy before that we won't get in a clinical practice. Antral follicle should be in each, minimum should be 7, but I say 8 to 10 in each ovary would be ideal. But AMH should be 1.5 to 3.5 nanogram. In those cases, you do not need too much of a dose. You may start with 225 IU, which I start. 150 sometimes doesn't work, but 225 seems to be all right, and sometimes even 300, depending on the age. That means the age factor, ovarian antral follicle, and the AMH will tell us the dose, but starting dose can be 225. Another category which we don't like in our clinical practice is previous history of poor response. Raised FSH initially, but we don't do that anymore. But AMH less than 1 nanogram is not too good. Consider a little higher dose of 375 to sometimes even 450, depending on the antral follicular count. So you start about 225 to 300, the other one, the best one. Other one can be 375 to 450. The minimum should be 225 in the first group, and minimum should be 375. But in European study says everybody should get 150. It doesn't work in our country, I suppose. Now, group C is the polycystic ovaries when there are too many follicles. When the AMH is more than 5.5, then you know this is going to hyper-response. I start a very small dose of 100 to 112.5. Then you find the response may be just average. But sometimes it doesn't work well, and then you have to increase the dose later on. So remember, the good A group is the best one. You start with 225, next one it may be a little bit more, 375, and then you reduce it in a PCO to 112 or even 150 is okay. You cannot say exact value, but the Nagori's table seems to be interesting after looking at it, and I've read that book as well. And the table tells us the approximate dose. But mine is a simpler version of not having a table, but to understand the patient's age, number of antral follicular count, and the AMH. Now, so we always minimize multiple pregnancies, minimize the number of embryo transfers, minimize patients' load and stress physiologically, psychologically, and financially. Now, when to start antagonists, to repeat that statement, follicle of 12 to 14 millimeter, estrogen more than 400, but sometimes take 300 also. If the follicle is more than 14 millimeters, estrogen is 300, you can still give. HCG or the recombinant can be given when the follicles are more than 18 millimeters, and 35 hours later is the oocyte pickup. Now, the role of luteinizing hormone in control stimulation is important to understand because granulosa cells are the only cells in the female body known to possess FSH receptors. Antrum formation requires stimulation by FSH starting when the follicle reaches about 0.25 millimeter in diameter. Granulosa cells only develop LH receptors when the follicle is more than 11 millimeter in diameter by about day 8 or 9 of follicular phase. So the LH receptors come by then. That is why I said start antagonist by 12 to 14 millimeters. If you wait for even one more day, she'll surge. Hence, LH receptors are present in theca cells and granulosa cells in the ovary. In response to LH, thecal tissue produces androgen that are converted through FSH-induced aromatization to estrogens in granulosa cells. Thus, ovarian thyroidogenesis is LH-dependent to a significant degree. LH activity is essential during follicular genesis and throughout the phase, but basically you'll realize that the early follicular phase and the late follicular phase both have a different kind of a role of LH because the LH initially increases androgen synthesis, stimulates follicular development, and later once again increases estrogen synthesis, the second part, and that controls follicular growth. LH surge more than 20 requires, we know it's ovulation, so the LH surge is prevented by either agonist or antagonist. So that's what I think is a concept of understanding, not allowing LH surge to occur, because if you find LH going above 20, sometimes even earlier, they have a LH surge. So we know there's a therapeutic value. Even the LH must be, when you start on the, let us say, stimulatory protocols where it's on agonist, LH goes down so much, less than 1.2, they start with HMG right from beginning. So I think the optimal dose of LH on the second is not dose. The value is 1.2 to 5. That will be the ideal day to LH when we really want to estimate. So serum levels of more than 1.2 are necessary to provide adequate LH support to FSH-induced follicular development in the total absence of endogenous LH secretion by the European study. So once again, to repeat, the low levels of LH is not good. High levels of LH is not good. The ideal is 1.2 to less than 5. So there are many kind of studies, but I just want to make you understand, when you do a good stimulation, we will get a good cumulus oocyte complex. So the pre-ovulatory surge of gonadotropin induces marked changes in both the follicle and the oocyte cumulus cell complex. Oocytes resume meiosis and progress to metaphase, that means mature oocyte, and cumulus expansion occurs or mucification occurs. If cumulus expansion is suppressed, ovulation rate is greatly reduced. So all this combination of FSH, LH will give us a good cumulus oocyte complex. So to probably summarize and thank you all, remember each patient is different. You divide the patient into a good responder or a poor responder and a hyper responder, and then decide on what's the dose depending on the antral follicular count, anti-Mullerian hormone, and so on. So thank you very much for your invitation and of course discussion.
Thank you, Pratap sir. It was really a wonderful talk, very useful. And we really appreciate you, teacher of all teachers. You're so humble and down to earth and so approachable to all the students. Thank you so much for your talk today, sir.
Thank you.
And
Thank
I
you, sir.
must add, Dr. Pratap Kumar is my best friend.
Thank you
So
very much.
he's very senior, but I always feel, whenever I see him, I feel like I just can go and say hello to him without even thinking twice.
My pleasure.
So, sir, thank you so much
And
for
he's
being
always
there. Being there. Very
Dr.
helping,
Monica
very
and dear
knowledgeable.
friends, he's always helpful to everybody. And still, I think he's our teacher professor. And I think when our children are going and grandchildren also, I think he will be the remembering as the great professor and teaching. Sir.
Thank you so much.
So
Thank you so much, sir, for such a wonderful talk. Do we have any questions? Or okay, so let's move forward for our panel discussion. Next slide. Yeah. So the today topic for panel discussion is how to apply ART law in practice. As we all know that this topic is very important for practicing ART in current situation after passing the law. And to moderate this session, we have very renowned clinician, Dr. Naina Patel, madam, and very famous embryologist, Dr. Randir Singh, sir. Dr. Naina Patel, madam, is medical director at Akansha Hospital and Research Institute, GVA IVF. Madam is considered as a pioneer in the field of IVF and surrogacy in India. She is President, State Ops and Gynae Society of Gujarat, 2010, Founder President of Gujarat Chapter ISAR. Madam was invited at Oprah Winfrey show, Hard Talk, TED Talk, Josh Talk. She has authored number of research papers, book chapters, and published various papers and reviewer of various journals. Ma'am has published first pilot study in autologous bone marrow derived cell therapy for thin endometrium patients in Journal of Regenerative Medicine. We welcome you, madam, today as one of our moderator. Thank you so much for joining us today. Our next moderator is Dr. Randir Singh, sir. Sir is organizing chairperson 27th annual ISAR 2023 Bhopal, ASHRAE certified embryologist,
Dr.
director.
Purnima, I have already introduced. Go
Yes.
ahead. Yeah.
Okay, thank you, sir. Our panelists are first panelist is Dr. Ashwini Kale, ma'am. Ma'am is chief embryologist at Asha Kiran Hospital and Asha IVF Center, Pune, Arunachal Pradesh, Hyderabad. Secretary, Pune Ops Gynae Society. Treasurer, Maharashtra Chapter ISAR. Elected MCA Embryology, ISAR 22 to 24. I think ma'am said that ma'am will be joining soon. Next panelist is Dr. Charudhar Joshi, sir. Sir is postgraduate in life science, trained in ART and allied procedure from Belgium, Singapore, Germany. Past Vice President ACE, past President ACE. Thank you, sir, for joining us today. Next panelist is Dr. Faisal Louis, sir. Sir is Professor in HOD Department of Reproductive Medicine and Surgery, Amrita Institute of Medical Sciences, Kochi in Kerala. Foxy Vice President is our National Executive Member, ICOG Governing Council Member, Vice Chairperson Kerala Chapter IAG, Secretary Kerala Chapter of ISAR, Reproductive Committee Chairperson KFOG. Thank you so much, sir, for joining us today. Our next panelist is Dr. Mahesh Koregal, sir. Sir is Director at Senior Fertility and IVF Specialist Consultant, Nova IVF Fertility, Bangalore. Exclusive infertility and IVF practice more than 17 years. Current Executive Committee Member of KSO South Zone. Vice President-elect of BSOG, Honorary Treasurer of Bangalore Ops and Gynae Society, Honorary Secretary of Bangalore Ops and Gynae Society, Chairperson Reproductive Endocrine Committee, KSOR, currently Executive Committee Member of KISAR 19 to 21. Thank you so much, sir, for joining today. Next panelist is Dr. Manish Pandya, sir. Sir is Professor in HOD Scientific Research Institute, Mahavir Hospital, Manish IVF Center, Sai Baba Ultrasound Center. Sir has received various awards and having various achievements into his credit. Sir has published sir is currently having ICOG fellowship in reproductive medicine and laparoscopy, 2 seats each, and having various publications. Thank you, sir. Our next panelist is Dr. Rohan Palshetkar, sir. Sir is Chairperson Foxy Young Talent Committee, Managing Committee Member ISAR, MSR, AMOX, Treasurer AMOX, Professor D.Y. Patil School of Medicine, Head of Reproductive Medicine Fellowship Program, D.Y. Patil School of Medicine, and so many awards into his credit. Thank you, sir. Rohan, sir, have you joined? Our next panelist is Dr. Varsha Jain. Unfortunately, madam will not be able to join us today. So I would like to hand over the session to our moderators. Our next panelist is Dr. Y.S. Verma, sir. Sir is sir is currently head director of Dr. Verma Hospital and Fertility Center, Gwalior, having interest in embryology. Current chairperson MP Chapter ISAR 23 to 25. Healthcare Award in October 19 for excellent work in medical field. Organizing chairperson MP ISAR 2023 Gwalior. Organizing vice chairperson of National ISAR 2023 in Bhopal. Thank you, sir. Next slide. Yeah, so I would like to hand over the session to our moderators. Thank you, sir.
So, good evening, everyone. First of all, congratulations, Dr. Randir and Monica, for organizing such lovely webinars. And this, of course, is the need of the hour. So, very nice topic for the panel discussion. So without wasting time, I will just start with the questionnaires. So we know that ART, Assisted Reproductive Technology Act, has now been implemented all over. And it has mainly going to touch the infertility, the social aspect, that the gamete donations, and also surrogacy. But today we'll mainly look at how we can practice lawfully in this era of ART Act. When the PCPNDT Act came in, we were really scared how will we go about. But now, as gradually we are moving ahead, we feel that this act has organized our practice, regularized our practice, but we should know our duties. So first question, which most of the gynecologists are confused when they do not have level 1 ART or level 2 ART and they are simply practicing OBGY, doing infertility. Can they give gonadotropin for infertility injection? I would ask the first panelist over here, Dr. Fessy Lewis. If a gynecologist asks you, can I give a gonadotropin injections? Is he or she allowed to do it without ART1 or ART2 level clinic?
I think that confusion was there in the initially. I think we cleared with our board doctors. They told that for as being gynecologists, we can even if you are not registered, you can use gonadotropins. Gonadotropins is a part of a routine practice, but just for using gonadotropins, you need not need a clinic registration.
Yes, but when you are using this gonadotropin, it is only for timed intercourse, nothing to do with IUI or IVF.
IUI, sure.
But
If you want to do IUI, your center has to have a level 1 registration has to be there.
No, but there is a gynecologist who does not have level 1 or level 2 clinic, but your patient wants to go there and take injections with her because that place is nearer to her and your clinic is far away. Can that gynecologist give injections for IVF or IUI with the procedure being done at some other place?
I think while doing the procedure you need a registration. Just for your ovulation induction, any gynecologist can use it. That was the clarification we got from our state authorities.
What does Dr. Manish Pandya think?
Madam, first of all, I would like to say that ignorance of law is not an excuse. You must know the law before you start any practice of ART level 1 or ART level 2. There are so many.
Even if you are not doing ART, you should know the law.
You should know the law. You should know the law.
That is
so
true.
ignorance
That is true.
of not knowing law is not an excuse. Somebody says, I am giving injection and I don't know what should be the implication. Sir has rightly mentioned that they had cleared the guideline for ovulation induction. You can use gonadotropin. But for IVF and IUI purpose, your center is not registered. Better not to do that type of practice because sometimes this patient go in OHSS, you are liable because you had given the injection. It's better to give at the places where ART center is registered. Don't encourage your gynecologists that you should give gonadotropin and you should give trigger and then you send patient to ART clinic because now law is very strict.
Anybody would like to add to this? Dr. Yatinder Verma or Dr. Rohan? Because there is some understanding. Dr. Randir, you want to say something on this? Yes, Dr. Verma.
Mahesh,
initially there was a lot of fear to start with, even to use a gonadotropin or even to scan a normally inducing patient also, people were worried. Now it is very clear saying that giving injections is not going to really matter much. And as far as the OHSS is concerned, always OHSS, whatever you practice, you need to take a consent of induction along with that consent of OHSS also. Because we have seen cases wherein patient has sued just for OHSS. So OHSS consent needs to be taken along with the induction consent. So that not to be worried. I think the gonadotropin can be used, ultrasound monitoring can be done, but then only the procedures like handling the gamete outside the body, like doing an IUI or doing an IVF, any of the handling of the gametes, should not be done. Other than that, I think its law is quite clear.
Yeah, so there is one more aspect to this, that supposing a patient from a remote area is doing IVF over there in Bhopal and she lives about 4 hours away, there is a local gynecologist there. That gynecologist can administer the injections, do the scan, but under the guidance of the clinic where the IVF is happening. So I give the protocol, I get the report on day 5 of the scan of the size of the follicle dosage. I will suggest when to add antagonist, when to reduce or increase the dosage, and what trigger and when to give. So either you have an MOU, which is not mandatory, but a gynecologist under the guidance of an ART level 2 clinic can also administer the injections. For that they don't need registration, but it is strictly to be done under the supervision of the ART2 clinic, and any complication happens, the ART2 clinic, who has guided the gynecologist and where the retrieval is being done, is responsible for that. That much understanding is there, right? Everybody agrees to that?
Yes, madam.
Yes, sir.
Yes.
Yes, sir.
So, Dr. Randir, you can take the second question now. Dr. Randir is not there. So I'll start again. Can one embryologist register work in multiple ART clinic? Dr. Ashwini Kale.
Yeah, hi, good evening, madam. I think, yes, a gynecologist can work in multiple ART centers.
Embryologist.
Sorry?
Embryologist.
Yes, madam.
Yes, yes.
Because you are working in Hyderabad, you are working in
Yes.
Pune.
Yes. So that
Yeah,
is
one
very
embryologist can work in many centers, but then the embryologist should also be responsible for all the paperwork that is happening at each and every center. Because though the embryologist doesn't sign anywhere, this doesn't mean that the responsibilities aren't there. Because whenever supposedly the inspection is there or the local body wants the embryologist to be present there, the embryologist should definitely be present.
Can I add, madam, here?
Yes, yes, please.
Yeah, embryologist can work to multiple centers. There is no objection to it as far as we know. But the only thing is that embryologist has to be registered with that center in this new law. And previously it was there, and still I think it is there, that at the time of inspection, they may ask the presence of the concerned person, concerned embryologist should be present there at the time of inspection so they can verify. So registration is must. It is just going here and there without registration, without signing paper. So that is, I think that is not allowed.
Very good point. Very good point.
Very
Yes,
good point. And madam, ART clinic registration has already one embryologist mentioned in their list. So your embryologist, first you are working with your place, embryologist, counselor, andrologist, your gynecologist.
The certificates have to be given for
registration. And suppose Ashwini madam is there with me in my clinic, so her name should be there on my ART registration certificate.
Very बहुत ही अच्छा point है. It needs a 1 minute detailed explanation that Manish Pandya sir, suppose Dr. Randhir Singh is your in-house embryologist and Ashwini is going to operate 1 ICSI cases. Your form, in the form which you have registered in the registry, her name should also be there. So, so that is important.
Yes, so today I've got 2 embryologists, both are sick. I called Dr. Charudat, come and do embryology work for me. That is not allowed. Dr. Charudat has to be registered with my clinic. Then only he can perform ICSI over here. That is the point. But if he is registered, I can call him. I can register 5 names also. But they should be registered.
They should be registered. They should be on your panel.
I think Srinivas is there, one of the ART board member. I am also there. Suppose, ma'am, there's a big center like you, and there are already 5 registered embryologists, and all the 5, because of some emergency, they could not come, and you have chosen a 6th one just within 24 hours. Then how to go with that? See, in medical ethics, in medical legal, that you can go in the good favor. So just, ma'am, inform email to a local CMHO and you go. You need not to get a seal and certificate that the 6th embryologist is not there. It's like that we do in a clinical practice. That's all.
Okay, so that is a good saving, rescue ICSI. That suppose it does not happen, you can inform your CMHO that all my embryologists are not present today and I have to do retrieval day after tomorrow. Because we will know 36 hours before that the retrieval is happening and nobody is there.
Yeah.
Then we can inform and go ahead. That's correct. That's what Dr. Randhir has said, right?
Yes.
Srinivas want to add something, I think.
Can I?
Yes,
Am I
yes,
audible?
Yes, sure.
Yes,
Sure,
yes.
Yes, yes, audible.
Sir, madam, first thing is that actually the embryologist working in a various center, this was a debate when the guideline was there. When the act has come, they have removed this part actually, as long as the embryologist is going to take a responsibility when they work, because it is not a simple work. He plays a very important role. Wherever he goes, his responsibility must be there. He has to take the responsibility. That is the clinician director who is there. No, it is their responsibility to make sure that he is responsible whatever is done. It is not like that somebody is registered, somebody is going to do it. And coming to the in case if he's not there, if he's not, that is what is the troubleshooting actually. In my opinion, I think if he's, as long as he's registered any one center, I think he will be called. It is not like that. No, he should be registered, then he should come. In that particular case, now when you fill it up the form, you can mention, because he is already the register, he must be having the number. It is not like that. No, you have to register another one and he is going to come. This is how it is going to be, I think, in future.
And what does everybody say? As of now, what we have understood is that a registered embryologist with your clinic can only do it. For example, my embryologist is ready to take the responsibility of XYZ who is coming to my clinic. Can we do it? That's what Dr. Srinivas is saying, that you can do it. But as of now, we follow that we have as many registered. Yes, yes.
Yeah. Madam.
I think the concluding remark is that Dr. Srinivas told that because, ma'am, it is like a PCPNDT Act. So if anything happens in the future, the whole people involved in the series will be taken the responsibility. So even if you have a registered embryologist and somebody is doing, it has to, as Srinivas is told, that it has to become in the paper of the responsibilities.
Madam, can I just add something? This is Dr. Rohan. Sorry, my network's a bit bad. Madam, we have multiple centers, but all our embryologists are registered at each and every center of ours, because the entire problem is we can't leave this interpretation to law, because it all then comes down to the interpretation of the law. I agree with what Srinivas sir is saying, that yes, you may be registered at one center, but currently I think till the law's clarity on each and every point is not there, I think it's better to be registered. And I think what Randhir sir said, that just inform the local, the CHMO, is more ideal to be medico-legal safe as consultants, because as head of units, we are going to be holding the sole responsibility of the entire plan. And Randhir sir, Monica ma'am, I want to wish you also best of luck for the elections as well.
Yeah. I think Rohan, you made the take-home message. I think that should be take-home.
Let me add one more point over here actually. Let me give, because the troubleshooting session it is actually.
Sure.
When I have a plan of 4 or 5 embryologists, no, I will register them. That doesn't matter. Okay, I have only one embryologist registered. Something went wrong. What I should be able to do it? It's very simple. In that case, I think this kind of system definitely will come into the picture. Like it is PCPNDT every day, whatever the procedure you do it. For example, today one pickup is done in a center. So many, this center can, this information go along with the embryologist thing. This is going to be there in future. Yeah.
Perfect. Because you're right.
So Dr. Randhir, you can take this question.
Yeah. Woman who was married at the age of 18, husband has a severe OATS, needs IVF ICSI. She's 20 years now. What are the options?
I think she needs to wait another year. I think 21 year. Unless she is 21 year, I think she can't go for treatment.
I think the other option is, according to as Mahesh told, personally, she has to wait till 21 years. Or she can go to the court to get exemption. Like that, what happened in few cases of not like this, some other instances which had in Kerala. They had to go to court and tell that. So court gave special instruction to do that. So somebody that's crossed 50 years and all,
who had their embryos frozen there and they could not complete the treatment. I think nearly 8-10 people got exemption from the High Court, telling that they can continue the treatment. So this is a genuine reason where she has to produce that she can conceive only through the IVF ICSI.
Yeah, perfect answer, Dr. Louis, but you have to depend upon the legal system also. So if she goes to the court and it takes 2-3 years, by that time she'll be 23 years. So that is
No. What happened is in Kerala, everything was all habeas corpus special thing was passed in 2 months.
Yeah, that's good. Yeah.
But
Sir,
we have the option of freezing the semen. Can we freeze the semen of the husband? Because oats, suddenly they can go azoospermic also. When the counts goes really bad, down, low. So can we freeze the semen of the husband?
Yeah, anybody can take. Mahesh sir, anybody? Yeah.
That can be frozen, but
semen can be frozen by anybody. Even unmarried man can also freeze a semen. So semen freezing can be done by it's a right of the person to freeze his semen. Even he doesn't need a consent of the wife also. Even the same with the oocyte freezing when a lady doesn't need consent of anybody.
Yeah,
I
so
think
here
semen
we
freezing
can do that. There is no confusion that a couple comes
There
when
is-
the female is 20 years and we don't do any test. That is not correct. They have not conceived for 2 years. You check the semen. If the semen is really occasional sperm count, you start pulling at least the semen vials so that when she is 21, she has got some sperms of the husband to go ahead and do the ICSI. So at least the screening of the couple can be done. You can't give a treatment of ovulation, induction, IUI, but we should find out the fertility potential of the female, even if she's 20 or 19, and the husband, at least a semen analysis to find out it is normal. Then call them after 2 years if they have not conceived. But if we find something like this, at least we can suggest that you freeze your semen vials and we do IVF when she is 21. Right? This is the message.
Yeah,
Point blank, we
think
cannot
Naina
refuse
ma'am,
a couple.
Yeah, Naina ma'am, I think to add to this also, Rohan, if he's there, he's getting a lot of patients from oocyte freezing and all. Suppose the same is vice versa, that a female is a 20-year and she has got AMH of less than 0.5. She can also pull frequent pickups at the oocyte?
No, that will be 21. That is coming under ICSI and IVF. You can give her medicine to improve the egg count, whatever you want to do, or if you need ovarian rejuvenation, that you can do. But you cannot do any ART procedure like IUI or IVF.
Mahesh, Dr. Mahesh, your version?
Madam, yeah, I'm a little confused here. I'm not sure.
For fertility preservation, we do cancer patients. But here, whether we can do it or not, because stimulation and retrieval is IVF.
So madam, her MH is 0.5 and she will wait for 2-3 years. So the MH will come to 0. You want to that? I think it's a gray area and it needs explanation.
So fertility preservation, we can stamp it and keep the eggs preserved. But we cannot fertilize the eggs.
Yeah, we can do oocyte preservation, but we can't do embryo cryopreservation in such a case. Because if we look at it from a breast cancer point of view, ma'am, if it's a 19-year-old or a 20-year-old who's about to go chemo radio, we can do oocyte cryopreservation, but at no point can we do fertilization or ICSI. We cannot do that. Oocyte cryopreservation can be done at the age of 20.
Yeah, because in chart they have mentioned that 20% of egg freezing patients are less than 20 or 20 years of age. So that is either for fertility preservation because of cancer or because of low fertility, like low AMH. So that message is clear.
Madam, we do a lot of semen cryopreservation. Out of that, even last 1 year, we had three boys who was less than 18 years who had come for a semen cryopreservation because of malignancy.
That can be done, fertility preservation. So here, as Rohan said, that you can't fertilize that egg, even if they are married couple, everything else is fine. Like wife has low AMH, husband has low sperm, then we can freeze husband's semen if it's severe oats. We can freeze the wife's eggs if it's low AMH, but we can't fertilize that. We can fertilize that only when she is 21 or years of age.
But this is a condition, but whether in the ART registry, then there will be a pickup of oocyte pickup for a girl less than 21 years. No,
Yeah, that
so
is
I don't
medical,
know
medical
how.
indication. That is
Cancer
medical.
also you do it.
Yeah,
But
medical indication.
But
That we
this
can do.
patient doesn't have cancer, no, madam. So wouldn't it be a normal patient
But
getting
when you
similar?
are freezing sperm of a patient who is oats, and where we know there are occasional sperm seen now.
I think, Ashwini, it's not that only it's a malignancy. Any medical, they have written a medical indication. So you can write anything under the medical indication.
But
okay.
IVF is in vitro fertilization. IUI is in intrauterine insemination. These two procedures we cannot do. For a donor, we cannot do egg retrieval if she is less than 23. But a patient wants her own eggs for her own self because she is Turner's. Supposing Turner's female will have menstruation from 16 to 18 years. After that, she might not have. Then we can do fertility preservation in the Turner's syndrome. Why not? OTC or egg freezing.
So I think to conclude that, ma'am, sir, the gonad cryopreservation we can do even if the age limits are not as per Act. Okay, I think it's clear.
Yes, but
Now,
not fertilization.
Yeah, not fertilization. Now, one situation I'm going because it comes in my mind. Suppose both are below the limit. Suppose less than 23 years, and you have preserved the oocyte. Suppose there's something comes, an arbitrary situation that she's going to lose her life or her uterus before 23 years. So why can't you get fertilized and get a pregnancy before she loses her uterus? Because at present she cannot take later on as the surrogacy because of our gametes and all. So this is a question mark, a loophole. What's the seniors think? Because that scenario might come sometimes.
That is illegal. Go to court.
Her
Go to
uterus,
court.
she can go for surrogacy. Na? She will have her eggs and semen preserved.
Yeah, so all these special cases, as Facey told, there should be a fast track and we should get limit results. Yeah, I think, madam, the next questions you can take, ma'am.
So this was a couple, husband 55 and wife 37. The first cycle was not successful. Now we have got frozen embryos, but the husband has completed 55, 56. What to do?
I think at the present law we cannot do that. That's what I told. No, in last after AFT law had come, we had three cases. Pardon?
Go to
court.
Yes, we got three patients who got exemption from the court, and we are done. And out of the two were the female had caused 50 years, and one the husband had caused 55 years.
Dr. Facey, an idea, whichever judgments you have got, if you can post it to the ISAR, and we all have a total registry of how many patients and which judgment gave them this permission, so that somebody goes in Gujarat, we have a presidential case, or somebody goes in MP, we have a case from Kerala. So we can produce that. So as an ISAR thing, what do you think, Dr. Randir? We should
that's a good point. I will take the responsibility. I'll take the responsibility and I'll compile all these such cases.
Very good. Thank you.
Yes, I'll give that. I'll give that. I'll give the references. I will give.
So we'll have that. Yeah.
Yeah. So there's from all the states, whichever state has got this exceptional judgment, we should have that judgment as a presidential case, and all the states in India should have them with it. So whenever we have a patient, we can produce that, give it to the lawyer, and it will make it very easy for the couple.
Yeah, ma'am. Next question.
So we should have Randir with us in ISAR.
No, he's always. You'll have that, yeah. And we have to choose a state also where the fast track is the fastest. If Kerala has got the fastest, my MP patient will go to the Kerala.
Yes. So now this is another issue, real life scenario, that a couple had IVF, they got a baby, their frozen embryos were there. Now the wife's sister, elder sister and brother-in-law, they also need embryo donation because both of them do not have good egg and sperm. So can these extra frozen embryos, they came for the consent that they want to give it to their sister and brother-in-law. Can we use that?
No, madam, we cannot use them as per the current law. They will have to create an extra donor embryos for themselves, where a specific egg donor and a specific sperm donor is used through an ART bank, and a specific donor embryo is made for them.
Family transfer in law specifically denied that from family donors egg and sperm you should not give. It should be anonymous. If they want
No. If he wants a sister to be a donor, it is easier to get a
I want to create controversy. Yes.
No,
Even in any
no,
altruistic donors.
Yes.
no, sir. That is not there now. I also have the same information that now this altruistic is not compulsory. They can be routed through an ART bank and they can use it. Like in this particular case, what she can in this particular case, what she can do is her
She
sister
can
can
give to the
again
ART
donate,
bank and ART can give to.
again donate oocyte. Husband again donates sperm, can make the embryo, and those embryos can be transferred. They will be
Yes,
the
have
donor.
to be
They will be
recruited
the
to a
simple donor.
ART bank.
Correct.
So that is what they did. They discarded their previous embryos and now they are creating new embryos as per egg donor selection, sperm donor through the ART bank and creating these embryos to transfer. So embryo donation is a big cross. We cannot do embryo donation now directly. So Dr. Randir, you can take this.
Yeah. Can the sperm donor donate semen multiple times to a single couple as per a new act?
To the single couple they can do, but only to one single couple they can donate sperm.
Even if the patient doesn't become pregnant after one IUI cycle or IVF cycle?
To that specific couple they can give.
Other panelists, please.
No,
Yeah.
each semen
I think,
sample can be donated only once, sir.
No, once even if the patient doesn't become pregnant, Faisi?
Then
Yes,
they can
it is
do.
the same way like an oocyte donor. No, even if the patient doesn't get pregnant or if there are no embryos created, that oocyte donor cannot be used again in the same way.
It's a gray area. चारू आपकी फोटो उल्टा हो गई है. चारू आपकी स्क्रीन सही कर दीजिए. Yeah.
No, a semen donor can donate multiple times to the same couple as long as it doesn't get pregnant.
Yeah, madam.
Supposing that patient gets pregnant, delivers a baby, and 2 years later they again want the same donor to have a second child, that also should be allowed. But one semen donor for one couple. That's
and madam, suppose vice versa also. Even the child dies, if the child dies, then
Sir, Randir sir, Randir sir, probably answer to your question is that you should be using or you should always take a donor which is the proven fertility one. Like if they have their own child, the donor has their own child, then there is less chances because if fertility is not proven for that particular donor, then this is possible that pregnancy is not happening alternately and so many times you tried. Law is law. Ultimately, this is a clear-cut understanding.
I think it's a
One
gray,
patient, one couple.
It's a gray area. I think the interpretation we got in Hyderabad panel, ma'am, Nana ma'am. So it was Dr. Banker was there. Many people were there. So what the take-home message was there in that, madam? Foxy.
It was that one donor, sperm donor, can donate to one couple. Even if it is 2 times or 3 times. 2 times they do IUI with the same, but they want the same donor third time. Even if it's proven and not getting result, they can use it. But that, yes. And they can change the donor if they want at the same time, but they can continue with the sample. So what we do here is we order 3 vials of a semen sample for one couple if it's IUI. And if the patient gets pregnant and delivers, we discard the other 2. If not, then again second time for IUI or IVF, the same sample will be used from the same donor.
No. You cannot order 3 samples because ART clinic is not ART bank. Whenever you are using for that person, I think you should order and use it off. We cannot store.
Very good question. Very good question, Mahesh bhai. Very nice intellectual question.
Eggs we can store.
No, ma'am, law doesn't say.
But that is what the practice is, that in sperm donation, at least 3 vials you can order. Maybe you can keep it with the semen bank for use.
We cannot keep it with us.
Second time again you bring the same sperm. A patient comes for IUI. He orders because the cost has gone really high now, a sperm donor.
And in that case, the egg donor donate for the same couple multiple times? No, that's not allowed.
No.
That is not allowed.
Then how is the sperm donor allowed?
Because sperm donation is an easy procedure. Egg retrieval is the procedure which is the government thinks is harming the female, so they don't want so many gonadotropin injections, the anesthesia, the retrieval procedure. Semen donation does not need that. Even in one ejaculation, you can have 3 vials. Simple. But we don't want consanguinity. That's why we don't want to split that donor to 2-3 couples. Only one couple, one donor.
No, madam, anyway, 2 vials minimum if we are planning IUI, so twice IUI has to be done, so 2 vials are required. And
Yes.
as an ART bank, now I have so many queries, so I started an additional vials frozen with me, which will be there for a long time with me, because I don't know after a year or 1.5 years that again demand come for the same vial, from where I will get the donor again. So I have to freeze those vials, extra vials with me, so that one donor, one couple concept. I don't know means what to do. So we supply usually 2 vials.
No, Charu, now question is that you're going to supply me on NMM the 3 vials or 1?
I will supply 2 vials. 2 vials, sir.
Double IUI has become a routine now when we are doing IUI.
So Ranveer sir, according to me, you have to just EMI of vials. First take a loan and take semen in EMIs.
Yeah, madam. So, because Naina ma'am, because most of the people now 80% they are doing single IUI. So if you're doing a single IUI and you're taking a 2 sample from my bank, it is illegal.
No, but we have to keep the record of each and every egg donation. We keep record of the eggs reserved with us.
No, madam, as Dr. Mahesh told that you are not a ART bank. If you have the ART bank, then only you can
we
store.
are ART bank. That's why. The ART bank.
No. The madam, see, we are this here we are discussing with ART2 clinic only. If they are not a bank.
If they are not a bank, they will not store it. But supposing an ART clinic does the egg retrieval of a donor that you have sent to her, and the donor is given 16 eggs, they have fertilized 7. Rest of the eggs which are there, they will not send it back to the ART bank through whom they have got it. They will keep it with themselves and they'll keep a record that these many eggs are remaining of this patient.
So that is a gray area, madam.
That is allowed. Then why not semen?
That is not also allowed, ma'am. For that,
no, we don't have to send back the eggs to you. Supposing your donor you send to me, I am an ART clinic. Right now, I am not a bank. Come on. And your donor gives 15 eggs. 7 I have fertilized. 8 I have kept it frozen for that particular patient. I don't need to send it back to the ART bank.
Ma'am, that is there. That will come to that point next, because USAID, ma'am, as we discussed in the Hyderabad, that the consensus was that you have to get fertilized only 7. You cannot create embryo of other things, and whether you have to freeze also not. That is a record.
Freezing is allowed. Freezing is allowed. Fertilization is not allowed. That's what is the last message.
Okay. That will come to that point. Yeah. The next question we are going to come.
Can I come in? Hello. Hello.
Yeah. Sure. Yeah.
I was just listening. Actually, I didn't get a chance to speak.
First,
for the
please.
previous one, madam, no, that is a tricky question actually.
Yeah, very tricky.
Donor for one couple. Okay.
Yeah.
There is a law says one couple, one donor, but science is not like that. No, if the pregnancy implantation is not taken place, you cannot blame the donor semen. No? If it is proven, is a proven. Sometimes it is a proven also, is a donating. If it is not happening with this, if you are not giving at a time, you cannot give a sample for 2 couple. It's fine. This is rejected. You know that this particular sample has gone there and you are not entertaining and you are not giving, you are giving. What if we can do like this? That's one thing. The second thing is this 7x fund. I really don't know, madam, because we need to understand the science before we formulate it. And I'm sure you are a clinician, you are expert enough actually. PCO is going to be no more actually, because we are the clinician, you are a clinician, you are an expert in tackling all those things. Okay, when you get an opportunity, okay, and there are so many paper actually now you get let me not put it in this thing. When you get so many eggs, all of them fertilized, all of them good embryos, you do find it. There are literature actually, human reproduction has come. In that case, no, I don't understand why we have to fertilize only 7.
Law says, Srinivas, law says that. RT
Law
says.
says, law say that you can retrieve, and law did not mention that you have to fertilize only 7. No, they will not
You
elaborate.
cannot retrieve, you cannot fertilize, no, Srinivas. That is the problem.
No.
If you cannot retrieve, you cannot fertilize.
No. It is said that however you can retrieve all the oocyte because it no
That is to prevent
That is to prevent
OHS.
That is to prevent OHSS.
Prevent
We have
OHS
to utilize only 7.
No, they did not say. No, I don't read it anywhere else. You can fertilize only 7. No, I don't think. Because always we feel that
it is not written anywhere. They've said retrieve all of them. What to do with the extra after 7? It is not written.
Madam, it is. Okay. Yes, madam. It's a good question. It is good that you have to retrieve. You should store them. We have really good vitrification method now. Don't we think that unwantedly we are exposing these oocyte for vitrification, which is of 15%. We can make embryo and keep it,
Yeah, but now the
problem, this is my part.
I see a very good difference that the oocyte donors are stimulated in such a low dose. Okay, you get 8, 9, 10, not more than like previously 36 eggs and 45 eggs. We are not seeing donors. So in a way, this has improved that the number of eggs from the donor has gone down.
You're definitely right, madam. Nowadays, it is a very history if you can get more than 15 eggs actually, because I don't want to go in depth actually. Even if you get 10, 12 eggs also, it is fine now.
Fine. Yes.
Nowadays, infertile couple equally good, better than this donor, because I don't want to explain things here. Yeah.
Now this legal question again, that a woman is undergoing divorce, but she comes for IVF or IUI treatment. Can we do it with donor sperm without the signature of the husband?
No.
Because she is legally married.
She can freeze her oocytes now.
She
can freeze her oocytes, but not make a donor sperm embryo as of now.
She has to complete the divorce process then.
Yes. Till then, only she can freeze her oocytes, not.
So the husband's consent is required. That is the RTI reply on 18/8/12/22. So these are all points that most of them we have discussed. Now, the insurance and the Aadhaar card. How many of you are having issues with the Aadhaar card of the egg donor? And when do you take the insurance of the egg donor?
That is IRP banks are taking.
Aadhaar card, always what we should do is there is one app called Aadhaar. So always download it in your phone. You can download it. You can verify the authenticity of Aadhaar card of the person by using Aadhaar. It's very easy, and you just try it. It's just an app. Just if you have your phones, just open your phones, go to the Play Store or iPhone store, type Aadhaar. You can find the patient, the donor's correct ID. You can find out and cross verify. That is number 1. Number 2, if you choose a donor, if you have a doubt, nearby any Aadhaar center for 50 rupees, they will verify the iris and the finger biometrics. They'll generate Aadhaar card in front of you. So that there are 2 ways to verify if you feel that's a bogus card. I mean, this is really worked out well, and just telling the other people it's beneficial.
Very good information. Very good information.
Very good. Yeah.
So this is because we as a clinician will be responsible if the donor comes and is repeatedly donating or the health insurance is not there. So as we have to check all the reports of the donor, we have to check this is a first time donor and confirm the Aadhaar card with this very good information and the insurance part. So it is our responsibility, even if the ART bank sends to you. As a clinician, we are responsible. So this was again discussed, Dr. Randir, if you want to take it.
Yeah. Who can be the oocyte donor? Can she be a relative? Can she donate again if the couple doesn't get pregnant?
Anybody can take it.
Yeah.
Ashwini,
I think any woman who fits the age criteria can be an oocyte donor. She can be either the relative or anybody, but she cannot donate ever again, only once. Whether you get embryos, you get pregnant, you don't get pregnant, once done is done.
Yes, very
let us understand why the government has made this rule. Government has made this rule because to prevent the harmful effect of the donation and retrieval for the donor. So one-time donation as well as 7 oocytes was prescribed so that you have minimum stimulation. There is no OHSS because people were harmed or some people even died because of OHSS. Government was caring towards them, so they said retrieve only 7 eggs and only once. So that is very clear.
So Dr. Charudat, can the egg donor bank or the sperm donor bank collect money from the couple, clinic or doctor for providing services?
Yes, madam. As far as my information is concerned, as an ART bank, if I am giving some services, I can always collect the service charges from them. I don't think there is any problem with that.
From them means couple or the doctor clinic?
Most probably, means what procedure I follow as per instructions after discussing with lawyers that patient, it is always better that patient should do the payment. So what I do is I ask the clinic to send me a requisition on their letterhead like we prescribe for the investigations. And on basis of that, that couple comes and that couple pays directly for the services of the bank, and the sample or the eggs are provided to the clinic. So this is how we proceed.
So they can charge for the expenses incurred. Again, RTI has given this reply on 11/11/22. Now, Dr. Randir, you can take this.
Yeah, can there is before that question, last question, take home message is that you cannot pay the enormous amount. See, you have to justify in the court that basically the law says that what losses the donor has got during that period. So you can
compensation to the donor, yes.
Yeah. So you cannot compensate that because see, there's a lot of way. If you can say the donation cycles previously when ART law was not there, usually we used to give some amount because this video is going to be recorded. So in the YouTube, so there was some compensation given to the donors. I'm not going to put the amount, but same amount or more amount you have to justify here. See, you cannot say that my donor from Gujarat or Tamil Nadu came to Bhopal and she stayed at a 5-star hotel. So staying for the 20 days cost 10,000, 2 lakhs plus food 1 lakh. So you cannot give like that.
Understood. Agreed.
Randir sir, you are muted.
Randir, you are muted.
Randir sir, you are muted.
See, we should remember that basic rule is it should be altruistic donor. The money transaction was not or prohibited, keeping in mind that this is a voluntary donor. So there is no commercial angle involved here. So there is no question of money to be involved. That was the aim. That was the aim of the bill or the registration, whatever has passed. So it's an altruistic or a voluntary donor. So the enormous amount of money question doesn't arise here because they are giving voluntarily.
Services.
Yeah.
Only thing that they can travel to and fro for injections or their food if they are there for food.
But you have to satisfy in the future because we be very careful because you are going to be in traps with the donor cycle, party
And
cycle.
insurance, what amount for egg donor you take?
See, they have panelist.
Charudat, insurance, how much insurance for the donor do you take and what is the premium?
No, the insurance now here, active banks take that insurance. So they follow our state body and they are consulted with that and they are taking that insurance accordingly. And more than that, the recipient has to give an affidavit. They are signed by the notary. They are willing to do this procedure and they know all the consequences. They are willing to take the insurance. Everything they have to sign before starting the treatment. Each donor has to do it.
Exactly. So now the recipient can know the identity because there is an affidavit going on. So anonymity does not remain.
In the affidavit, that portion is not there. That will be adding that because that anonymous we are still maintaining.
I think you have to write down.
How you can do? How can you do?
You have to write down. Anonymity is not that. Confidentiality of the procedure we have to maintain. That they have done egg donation, nobody should know.
See, this
but
is
anonymity will disappear because we have to write in the name the affidavit. What do you say?
Yeah, there's
no. In the affidavit, what we are filling that we are willing to do it. The specific this thing is not being made to affidavit, so that we are willing to do that, or we are willing to take to the insurance for that. We are not revealing their number or identity in that.
There is no, see, even if they bring somebody from their side who is voluntary, wants to donate altruistically, we can take them. So there is no.
We can take them. That is to be through the ART bank.
Yeah,
so,
they send them to
so
ART
we
bank.
we don't encourage that, because in long term it is that will lead to a lot of problems. So we don't encourage that. Only if they're coming through the ART bank only, we will take that.
ART bank is not supposed to recruit the donors. ART bank role is only to register the donors and send them. They are not supposed to bring the donors. They don't no more. They cannot act as a recruiter. They are not. They just can register a donor.
They cannot be agents. They cannot be agents. Yeah,
They cannot be agents. They cannot be agents. They can only act as a clerical kind of a just register the donors, so that once the ART bank registered go online data across India, so that one donor doesn't donate again. So that to confirm, they take the records of Aadhaar cards of them. But that does not mean that they only can bring the donors. No, that is not there. The voluntarily
through the ART bank only, somebody was coming.
No. It's ART bank only can maintain the data. That's all. The clerical work. They cannot bring the donors. They cannot recruit the donors. There no more agents are involved. Those errors are not there. Now only they can register. They can maintain the data only. The voluntary donors can the recipient bring, or somebody like a blood bank that can come and donate the eggs. But then there is no recruitment that is not allowed.
Yeah, to coming to end, Mahesh bhai, this is a very important topic. Everybody should listen. That is very important, that the role of ART bank is just a clerical. He cannot pay anything to anybody. He cannot recruit anybody. So important thing is that all the choosing of the donor has to be done by the couple. The couple has to put the person A and B is my donor. He has to take all the insurance and everything.
Dr. Randy, if a lady comes to an ART bank that I'm interested in donating, I just want to donate eggs, like we go for blood donation every 3 months. Supposing a lady goes to Dr. Charudat's clinic and says, I want to donate eggs.
Yes.
That can be there. Then see, it's a demand and supply. So ART bank will say that I have got this 10 list and there's 10. Yeah.
It is just like blood donation. You don't pay for a blood donor. Blood donor is not commercially cannot pay. It's a voluntary. Same way.
Yeah. Same. Yeah.
So, and then you can take this question.
Yeah. A couple had IVF baby delivered in December 22. Both husband and wife filed for a divorce, and they have a frozen embryos in our hospital. Who will have custody of those embryos? So it's basically they are both fighting each other, and what the role of ART center is there.
Court has to decide.
The court will decide. It's a joint property.
Yeah, because our embryo transfer and the freezing form does not have the clause of in case of divorce who will keep the embryos. They can either discard, donate frozen, discard embryos, give it for research to the authorized research institute, or if they both die, who will be the custodian? And this point that if they divorce, who will take these embryos? That should be added in the format of the embryo freezing form.
Madam, these all are just like unborn babies. They can fight for born babies. They can also fight for unborn babies.
Unborn babies, true.
So, madam, suppose if anybody is coming and you are giving this consent that the future embryos, you are free to give a right to husband or husband to wife.
We have to add this. If they divorce, like if it's an egg donor, this couple was an egg donor. So the husband says, this is my genetic material, I only can get it. And
even this is posthumous donation. Even if one dies, the other cannot use without, because posthumously before death, if the consent is given that after my death, my wife can use. Because the property matters and all, they cannot use. If the husband has died before death, the consent is not given, they cannot use. Same
they
thing.
Cannot transfer without the consent.
They cannot transfer. Second is if the sperm is frozen of somebody and then the parents come and say, I want to transfer it to somebody. They
No,
cannot
no,
keep.
no.
That's what
Yeah.
these are not allowed.
These are very important, Mahesh bhai, because all the prior to death or prior to court, all the consent has to be given by the persons, either husband, wife, or both.
So, madam, now we have to put in our will also that my sperm are located there, my embryos are located there. Those who want to fight for this, just have a club. So, rather than property, you have to show your sperm and gametes to the will also.
Yes, and otherwise we go to Kerala High Court to get a proper judgment.
Casey will take us to the first court.
Yeah, fast toast. And one thing here to modify this question again, Nana ma'am, suppose one of the partner dies and the partner remaining wants to go. I think same law will apply for that also.
Yes. So at the time of embryo freezing, all this consent should be taken. Discard or don't give it for research. But
Research
suppose one dies, the other has the right over it.
Yeah,
Both
yeah,
husband and wife. Or if they divorce, who will have the right? Or if both of them die, who will have the right over these embryos? These many consent should be taken at the time of embryo freezing. That is
Actually, Nana ma'am, we used to do all this through all the surrogacy patients. Yeah, ma'am, because my surrogate
now
patient is.
the embryo freezing format does not have all these points.
Yeah,
Similarly,
yeah.
with embryo transfer, this patient.
Madam, now we should write nominee name also.
Yes.
Yeah, that we used to. Dr. Manish sir, we used to do a lot of surrogacy. So I used to do all that. If both the husband wife dies, who will take? The parents will take. We had that consent form. Yeah, yeah.
Yes.
Yeah, nominee.
So now this is a real scenario again. Couple came for IVF, the result was negative. 2 months later, the wife again comes that my frozen embryos are there. Husband was not with her. So I want to now start the treatment. So we started preparing for the FET. But just before the embryo transfer, we came to know that they were taking a divorce and husband was not interested.
No, can't do it.
But our IVF consent is one-time blanket consent. Is there a form for embryo transfer? There is a form for signature for
FET frozen embryo transfer time, we take a separate consent for each time embryo transfer.
Each time you have to take. Each time.
ARD Act does not say that. ARD Act, you just take one. Where is the consent for embryo transfer, frozen embryo transfer? Nowhere there is an embryo transfer consent form.
No, that consent form, what is written in ART Act, that has to be filled every time when the procedure is being done. It doesn't say once. Yeah, whatever form is.
For our safety, we do it, but otherwise, a patient can come and get it transferred, and we will not know, because the first time when we do the counseling and take the consent, that is the only form. Every time there is an embryo transfer, there should be a consent form to sign it.
That embryo transfer consent form we take every time.
Every time ET form is filled in, no, madam.
Every time.
ET consent form hai hi nahi kuch. You
No,
see, check all the forms.
The same ET consent form has to be printed again and taken along with the witness in the clinic.
Yes.
Mahesh sir, and suppose I have done a consent in December and patient is coming in January. The same consent form, I can write a line, a date. No, date.
No.
On the date of embryo transfer, you will get a fresh consent form. No, sir?
Yes. Fresh consent each day of embryo transfer with the date we have to take.
Date and time.
Though the form says ki sign of the husband if applicable, but we have to take the sign of the husband.
It is compulsory.
It's applicable, and it is like there is no separate. But these are the points which ISAR and IFS should look into it and improvise on the consent form. So it is making it very clear for the couple and for the clinicians also that what they are supposed to do and what they are not supposed to do.
Ma'am, I have one question here. That means that husband should be present on the day of embryo transfer.
Absolutely, but husband is
sometimes many times we have patients from abroad.
No, I totally disagree. No, the presence of a husband is not required on the day of procedure if he has given already the consent, because the husband is in the army at the Siachen. How he can come? So I think.
But then he should send in an email or give a written consent that he consents to this embryo transfer on this specific date.
So video recording or an email should be there.
No, I don't know. See, suppose now patient comes and during preparation, before OP or anything, if they give the consent that I'm ready for ICSI and embryo transfer, why he should be physically present after 1 month or
No,
if it is like
Supposing
Randir,
that separating husband is not interested in a baby and something like this happens.
It many a times happens
Randir,
that they don't
Randir,
want.
if he gives a consent that I am willing to do the embryo transfer in my absence, then we can do it.
Yeah, therefore I'm saying, he need not be physically present.
No,
He's
but he
got
has
right.
to give that specific consent for that
Consent,
baby, sir. I
correct.
mean,
Yeah,
it
yeah,
cannot
yeah.
be a blanket thing that the wife will come
Yeah.
after 3-4 months.
No.
Yes.
Yeah.
So now I will want all the, because this act has made us more organized, the quality of treatment, legal protection, national registry. But what are the burning points or one take-home message which all the panelists would like to give?
Before this, ma'am, one question. Before this, madam, one question is there. We'll include this part in next panel, the moderator. We have done embryologist that they can visit 1 or 2, 3 places. But what about the clinician, Dr. Naina Patel or Dr. Monica Singh, going for Gujarat, Maharashtra, Madhya Pradesh? What is that?
Clinician can go anywhere.
They can.
Provided he has a registration there in a PNDT. He has
Yes.
to do up embryo transfer under a scan guidance. So he has
And he
to
also has to take specific MMC registration of the different states.
the
also.
Yeah.
PNDT.
So now here comes the point. What difference is that embryologists, they don't have an NCI registration of every state. But Dr. Mahesh Bhai, if he's doing it Bangalore, he want to do an embryo transfer to my Bhopal, he has to get a practitioner
Madhya
NCI
Pradesh
registration.
government.
Yeah.
Yes.
Yeah.
You can't practice there. You can go and counsel patient over there, but you can't go and do a
No,
pickup.
no, ma'am. No, for consultation
Unless you
also.
have that certificate of practice.
No, ma'am. For consultation also, ma'am. Any practice, you have to be registered
Registration
at
would be
NCI.
mandatory.
Only
Yeah.
counseling can be done.
I think counseling doesn't come in the medical practice. The counseling does,
But
word
supposing
doesn't
there
come.
are junior doctors who check the
More-
patient, who do their
more than-
sonography,
Yeah.
and they give us the diagnosis that this patient has this. So we can always counsel the patient that your next step ideally is not a laparoscopy. First, preserve your embryos, then plan to do a laparoscopy. That can be done anywhere. Remotely, you can do it on video also, or you can do it, but you can't physically do a sonography.
Yeah. So no,
That
ma'am.
all
You're
you can't.
talking. No, you're talking about telecommunication, like
Or even
CT scan
if they
reporting.
come to Bhopal to your clinic.
Yeah, physically, if you are
Monica has
coming.
seen the patient everything. I just
Yeah.
need to say that I feel I do this for this
Yeah.
patient.
Yeah.
Right? That's it.
Yeah. So, yeah. Now
Now
we can.
everybody can give a take-home message to the audience what they want to give.
Yeah.
I think RT Act, as Madam told, it is becoming more organized. That is good thing. But it needs few more things which has to be more patient friendly and which will not put burden on the patient. So that the few pitfalls has to be organized by including few doctors into the RT council and making the amendments accordingly.
Yes.
I would like to say, but can you just stop screen sharing? I want to share a small gazette so that there is no confusion.
Sure.
Yeah.
You can just stop sharing.
Yeah, team in task, please allow him to share. Yeah, please allow him to share. Vishal, Dr. Vishal, allow Mahesh, sir, yeah.
If you stop sharing, I'll be able to share.
I'll do it in a second. Please. Yeah.
Just a minute, madam.
Yes, madam, in nutshell, we must follow the law. According to Dr. Facey, there are some amendment, but this is not possible in Indian scenario. Once law is made, then to make some amendment, it is a great process. But we should strictly follow the law whenever possible. Don't harm our patient. Do the justification with ART bank. Now we have got one HDFC like one ART bank, so we have to must have a good relationship between our ART bank and clinic, so we can take the semen in EMIs and we can take embryo in EMIs, and we should follow the law. Yes, sir. We cannot see your screen, sir. Randir sir, duplicate.
Just a minute, sir. Little bit.
Yeah. Meanwhile, you can just I was comment of the one Dr. Yatindra Verma has told me that apart from MCI, you have to get registered. Naina Patel ma'am or Ashwini, they have to get registered at my center in ART registry also.
Yeah.
Yeah, ART practice.
Okay.
So, yeah, Mahesh sir, if you can start.
Can I see my screen?
We are watching your screen, but yes, now we are watching your screen.
Yeah, now you started. Yeah, you can share slide. Yeah, Mahesh sir.
Yes.
Yes, it
See,
has
that's
gone
the
again.
gazette I wanted to show, which clearly states that.
Sir, gazette has already gone again.
Gone.
The
It came once and then it.
Sir, your gazette has came, but it has gone. Yes.
Yeah. The only thing, the Gazette of April 2023 was clearly of the state that you should make an effort to retrieve only 7 oocytes, and anything more than 7 oocytes, you should not try to retrieve. And if you retrieve also, that is just for a prevention of OHSS. That cannot be used. So usable oocytes are only 7. So that is the I wanted to share that.
Yeah. So that is
Gazette,
perfect.
somehow I'm.
That's there always. So yeah, that is there. Because we are totally, because it's a gray area now. Because
this
the
is it's not a gray area, sir. April 2023 regulation I'm showing you now. You can just Google for Gazette April 2023 ART regulation. That has actually Gazette.
No, Dr. Mahesh, I totally agree with you. What Gray I'm saying is that they have not mentioned about the retrieval of more than 7 oocytes, whether to fertilize, use, or throw and all. They have told that you do the retrieval, rest what? Because you cannot throw the embryo oocytes.
No, you
So
have
that
to. You have to. You have to.
So you have to throw, because it is not clearly mentioned that you can use or store.
In the first place, the ART Act was clearly to prevent OHSS. If you are not to throw, then people again will start taking 80 oocytes, 100 oocytes. Again, it will become same. Again, 100 oocytes you can take. What is the point?
Yeah. So ethics, there are sometimes you have to be totally perfectly. I agree with you. Ethics plays here a role. The ethic was that not to overstimulate, and if you start using, then the ethic behind the law will not get. Totally, I agree. We should follow this. Yeah, it has come now. Yeah, we can see Mahesh bhai. Yes.
Can you see this?
Yeah.
See, number 2, manner of retrieving oocytes, clause 24. Clinic shall retrieve 7 oocytes only. Can you see there? Make efforts to retrieve not more than 7 oocytes during one cycle. Provided that clinic shall retrieve all formed follicles. Formed follicles you take. Then they are not talking about oocytes. Oocytes number is 7. Remaining are just consider follicle puncture and remove and throw it.
So take home message is that after 7 oocytes in the embryology, Charu, you have found out, you have to say, Naina Patel ma'am, now it's full. Now the train is full. All the AC1 is full. No, you have to do the pickup and throw into the dustbin. That's I think. No.
That's
yeah, Mahesh. Yeah.
You can see this act.
It's very clear. It's not clearly. Yeah, Naina ma'am, we have
or
to.
the other thing is, rather than discarding at that stage, you puncture and retrieve all the follicles. The 7M2 best you can use, the others you discard. Because if you retrieve first 7, there could be 3 GVs also or 1 M1 also. So why not give the advantage to the patient of best eggs?
Mahesh sir, answer to this we have discussed in the
So
Hyderabad
you have to retrieve all, but use only 7M2.
The 7 best M2, yes.
Best we cannot freeze. Best we cannot freeze.
Whether they are M2, you have to discard rest of them.
Yeah, but not just after getting 7.
No.
Now, Ashwini, you have taken the 7 oocyte. You have suppose taken 14 follicles, and you got 10 COCs. You did the denoding. You got 7 M2s. It's perfect.
Yes,
now,
that is perfect.
Suppose you have got 14 follicles. You have got 10 M2. And
so
out
I
of 10
use
M2,
7 best M2 and 3 are to be discarded.
No. So if you are doing a 7 ICSI, you will choose the best M2s. Okay? So you have to
No
instead of
option now left.
no, so you have to choose the best 7 M2s out of the total pickups. That's okay.
Yes. Yes.
That implies for the ICSI, that implies for the IVF. But
Yes.
in IVF, how will you come to know which are the best M2s? Because it's a COC, you
So
don't do
we
denuding.
anyways don't denude in IVF. So whatever looks best to the eye is to be used. It would
No.
be a gamble, but it has to be 7 now. Can't do anything.
Yeah, the law means that 7 oocytes you count and then stop counting, and others are follicle, just puncture. That is the aim. What M2 and all we're talking is just our this thing, convenience. But then it says count 7, then stop counting, no matter what
No,
it is.
no, Dr. Mahesh. Here you have no.
Say retrieve all and use 7. Is
Show
what
me
they
where is
Use 7. Yeah,
is
yeah. I think Ashwini is perfect. You retrieve all, choose the appropriate best, either COC or the M2 if you're doing ICSI, and then rest through it. I think
Exactly. That is the
Yes.
best. They have not
Yeah.
written to throw
But
because there is a
They use for research
confusion.
purpose.
I am giving the carry-on message what we have discussed in lots of other panels, that you can freeze those for the patient's future use.
and waiting for the order from the ART registry center.
Yes.
What to do?
So probably you could take it up with the lawmakers about this number or the remaining eggs.
Yeah. That's
Naina
good. I
madam
think
is there, you are there. So probably
नैना
something
मैम
should be done.
you have to मैडम आपको स्वास्थ्य मंत्री के कान में ये बात डालनी है through your state कि this is a scenario. Yeah.
State code
I
में तो
think.
definitely we will discuss.
Yeah.
So I think
So now,
yeah.
So now we'll come again with the now finalizing. Thanks, Mahesh bhai, for this. Now one by one, before we conclude, we'll come to the your concluding remarks to the ART bill. That could be anything in the 4 or 5 subheadings. That how easy this act is, what are the loopholes, what you want to changes, and what advice, so that we can compile. We have compiled in Hyderabad also, ma'am, points. So here also we'll compile one by one, all panelists. Yeah.
Yes.
Sir, I think the answer to this is follow the law to the T. Wherever you think there is a gray area, better to leave the patient at that point and follow the law no matter what. Be safe in your practice.
Yeah.
That is it. And the law has actually regularized the practice and it has made it a little easier also.
Yes.
Anyone
Next, please.
Follow the law. Live in peace. Have a lawyer with you.
Yes.
Because since I started my practice, one lawyer is with me since 2009. My all patients are undergoing registry with notary also. So we don't have any burden. Keep a lawyer with you. So you are in a safe guide. This is for me. If you have got multiple practice, you can't.
I think Jaideep sir has joined. So we can
We'll take a last word from our president.
Yeah,
Yes.
Jaideep sir has joined. So if he's free, Dr. Monica, I think,
Yes, good evening, sir. Most
Good evening,
welcome
President.
to. I told you Dr. Jaideep Tank has been so kind enough to join us twice in a matter of 4 or 5 days only. We are so thankful, sir, from your busy schedule. You have, joined today to grace the function, and it's a really moment of honor for us. So we would like to have a few words of blessings from you.
Thank you, Dr. Monica. Am I audible?
Yes, sir.
Yes.
Let me begin by congratulating Dr. Priyankur Roy for putting this webinar together. I worked with Priyankur for a very long time, and I know that during COVID times, I used to call him National Coordinator, not because he was the national coordinator for anything, but whatever seemed to be happening in the nation, he only seemed to be coordinating. So he was so busy, and I think he's still very busy, and he has, of course, accomplished a lot. He is also the chair of WATOG, and I think, I wish him all the very best for all his endeavors. Let me acknowledge the Secretary General, Dr. Madhuri Patel, Ajay Mane, the Vice President of the Public Awareness Committee, which has put this program together. And of course, such a pleasure to be a part of the program with Chief Guest Dr. Dheeraj Gada, Naren, Rishikesh, Amit, and the guest of honor, Dr. Virendra, Dr. Srinivas. And congratulations also to Dr. Randhir Singh, Dr. Monica Singh, Dr. Manisha Jain and Dr. Purnima Tiwari, who are the convener, co-convener, and the coordinators. I'm sure it must have been an excellent webinar. I'm sorry I missed it. I was in a flight from Delhi. I've just landed back in Bombay. So you'll have to excuse my joining a little late. I should have joined earlier. But you know, the Delhi fog was particularly dense today, but luckily the flight took off and landed. So let me not come in the way between you and your discussion. Let me thank all the faculty, speakers, Dr. Nagori, Dr. Pratap Kumar sir, chairpersons, Monica, Priyankur, Ashish, Manoj, and of course all the panelists. I did drop in. I saw you all were having a very engaging discussion led by moderators Dr. Naina Patel Madam and Dr. Randhir Singh, and panelists Ashwini, Dr. Joshi, Fesi, Mahesh, Dr. Manish, Rohan, Dr. Varsha Jain, and Dr. Yatindra. So again, let me say thank you to invite me here. I'm sorry I joined late. As I said, I was in a flight and I've just landed. And all the very best to all of you. I know it's not a proxy election, but let me wish all the very best. Every election is important. So let me wish very best to everybody who's contesting for the ISAR elections. I understand the IAG elections are also around the corner. So all the very best to all the candidates. Thank you very much again for having me. Thank you.
Yeah. Thank you, sir. 1 minute, I'll take you, sir. You are at present our national head. So we have got many loopholes in the ART Act. So along with the ISAR and IFS and ACE, we'll be needing your support, our support, national head, to convince the government at the Delhi that what is difficulty we are getting in the implementation. Few topics.
In fact, I was at the ministry today. That's why I'd gone to Delhi. I had not gone for the ART Act. I had gone for some other work.
Yes.
And I must say this, that the ministry has actually been very responsive. I
Yes.
don't know how many of us realize, but the ministry has put out 91 orders of various kinds. I'd made an analysis for this because I'd made a presentation on this in a WHO meeting recently called the current status of the ART Act. And if you look at all the notifications and gazettes which have come out after the act has been promulgated, 91 notifications, gazettes, GRs, and orders of various kinds have been promulgated by the government. And you can see that there is a bit of a more clarity around the act. Much more clarity is needed. I'll refer you to my recent publication published in the Indian Journal. I did a survey on the providers' reactions to the ART Act, and there were some very significant findings. It's free access. You can just search by my name. It's co-authored with Dr. Prabha Kottiswaram, who is a professor of law at the University College of London. So I'll encourage you to go through that. We have sent that publication to the government and we received acknowledgement for it. So hopefully things will get better. I think what is important is that the government's willing to listen. I think, and that is reflected in the fact that all these huge number of GRs and notifications, I've been a part of policy making for a long time, almost 22 years now. And I've never seen a government coming out with so many GRs and so many clarifications on any healthcare related act. So I think that's a very encouraging sign, and hopefully we will have more clarity as things go along. Thank you.
Yes, sir. Yes, sir. And they're very frequently doing it. So, but they're not waiting for giving a long time. That is a very good thing for a present government. Yes.
Yes. Yes.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
I think with this, we will have to conclude, Dr. Randir. We have got a very dynamic president right now who will take this. And we are going to get good managing committee members in the ISAR clinicians as well as embryologists. All we need is that it should be same all throughout India. The appropriate authorities interpret in the same way, not different in one district and different in another district. If we come to do that, lot of things will be clarified. And at the same time, the few loopholes that we discussed today, if that is addressed, I think this bill, we will enjoy practicing ART in the future with the changes that we are looking at. Thank you so much. Best wishes to Randir, Monica.
Thank you. Thank you,
ma'am. You are going to be elected.
Yeah. Thank you.
Thank you, madam. Thank you.
Thank you.
So,
all the best.
I thank
Randir sir, Monica madam,
I
and
thank all of you for being here. I thank all the speakers, moderators, panelists, my MOCs, And especially thanks, sir, for joining our respected guests of honors, our chief guests, and of course, Team INTAS for giving us this academic platform. We could not have done this webinar without all of you pitching in for over 3 hours, and it has been wonderful. I hope we have many take-home messages, and we continue to improve our practice as gynecologists of India. Thank you so much.
Thank you.
madam.
Thank you. I think
so
Monica has concluded. So our aim was that this excellence webinars is that we have to be excellent in law as per ethics. And thanks, sir has told that he's always behind us, and he has been doing last 20 years. So I was literally no safe, like a baby safe in the mother no of father. So I think we are safe with the Foxy president and all these committees. So I think thank you.
Thank you, Priyankur, for giving us the opportunity to work with the public.
Priyankur, you can have a comment final.
No comments, sir. It was a wonderful webinar. Thank you to everyone for being there and for the support and organization, Randeep sir and Monica ma'am. And I especially like to thank Jaideep sir for joining, and of course Dr. Ajay Mane sir for joining as well. So thank you so much for the beautiful comments. And of course, I'm very thankful to Manish Pandya sir, Dr. Yatindra, Fasi Louis sir, Dr. Mahesh Koregal sir, Dr. Manisha, Ajay Mane sir, and as I've already mentioned, Dr. Shatabdi, Rohan, Dr. Randhi sir, and for the beautiful comments. And this was eye-opener because, when sir was saying that this topic will be very, very useful to everyone, there were at least some 5 people who in between said that I could not join, they could not join, etc. They were saying, so the link was sent again and they could join actually. So basically people want to listen about a topic like this, which was very aptly selected. And I would really like to again thank Randhi sir and Monica ma'am for bringing this whole thing up and doing it so aptly. Thank you so much, and thank you to all the experts for giving a beautiful inputs. Thank you.
Yeah, we'll be having a YouTube link record of our all, so that will be useful for everything. And I think best wishes for Happy New Year to everybody. Thank you. Thanks a lot. And Vishal, you want to say, Vishal, few words from INTAS? One last few seconds.
Thank you very much. INTAS will always provide such platform for the scientific deliberations. Thank you.
Dr. INTAS, I think Ratin Verma sir is having some problem in unmuting him. Just see.
All these webinars of perfection, excellence, and symbiosis are available on YouTube. So anyone who misses or who wants to teach students or wants them for future reference, please kindly go to the YouTube and you will get the link. Thank you so much.